live in a second.
So good evening, everyone in India, and good morning, everyone in South America. I welcome you all to this 8th Shoulder Planet webinar with an association with OrthoTV. And to introduce today's speaker and the topic, I hand over to our moderator, Dr. Sergio Rowinski.
Oh. Okay, lovely. So good morning, everybody. Good night in India. Hello to my friends. I'm Dr. Sergio Rowinski from Shoulder Planet, here from São Paulo, Brazil. And it's a pleasure to be with you, my friends, in our 8th event, which is going to be very nice today. We are going to discuss different things. And I hope that everybody really likes a lot. So today we have special thematics with special team. So we will discuss soft tissue management with a very good specialist, Dr. Guido Carabelli from the city of Buenos Aires, Argentina, who is here. It's a pleasure to be with you, Dr. Guido. It's an honor. Dr. Guido, he will introduce himself in a second. He's from AO faculty and a big specialist in many things, and in between them, soft tissue reconstruction. We still have from India, my new friend, my good friend, Dr. Gadegone, the famous Dr. Gadegone from the city of Chandrapur in India, in the state of Maharashtra, who's going to talk about his unique techniques on humeral nailing, on clavicle shaft nailing, and we will have a lot of opportunity to discuss this. And my good friend, who is now for the second time, is the second but nevertheless, Dr. Robinson Pires, my good friend from the city of Belo Horizonte, Brazil, who is also an AO faculty and my good friend for a lot of time. And we have today the presence of another guy who is my good friend, who is Dr. Hélio Cunha, here from the city of São Paulo, Brazil. He's a reconstruction surgeon. He does Ilizarov, very talented guy with a very good, serious theoretical background. He works with me in my public hospital, from which I have been doing the traumas that I've been showing to India for the last 12 or 13 years. So this is going to be very nice. I hope everybody enjoys. I would just ask the panelists just to say hello. I guess we have more than 1,000 people seeing us. So Dr. Wasudeo, I just want you to say hello to everybody. Just put your mic up.
Hello. Hello.
Yeah.
Welcome to this very prestigious webinar organized by our friend Sergio. And it will be a very good event, and we'll share our knowledge and small techniques they are done in a rural part of the India, and I hope it will be digested by all AO people, those who are here as a faculty and panelists. Thank you very much.
Thank you, sir. It's a pleasure to be here. Robinho, just say hello to everybody. My good friend, Dr. Robinson Pires.
Hello, Sergio. Hello, everyone. Thank you very much for inviting me once again. Thanks, OrthoTV. I hope that we are going to have an excellent meeting once again. Thank you very much.
Lovely, lovely. Let's just listen to Dr. Guido, our specialist from Buenos Aires, Argentina. Please, Dr. Guido, just say hello.
Hi, Sergio. Hi, everyone. It's really a pleasure to share my time with you and all of you in this OrthoTV. And yeah. I hope you can find a time fine.
Yeah, okay. Thank you a lot. It's a pleasure to have you here, Dr. Guido, in OrthoTV. Dr. Hélio will just say hello to everybody and just we can start. Dr. Hélio.
Hello, everybody. Good night.
Okay.
Good morning.
Yeah. Okay, lovely. So we will start, my friends, with soft tissue reconstruction with Dr. Guido. He's a specialist. He will introduce himself and we will see his interesting lecture, and then we will have a lot of time to discuss this before we go to the next topic. So Dr. Guido, the microphone is yours. Thank you a lot for being here in my name, in the name of Shoulder Planet, OrthoTV, and we are all ears, my friend.
Okay, thank you very much, Sergio, again for the invitation. Let me, here. Okay, well, we will start. I'm Guido Carabelli from Argentina. I'm orthopedic surgeon. And I think that is important because I'm not plastic surgeon, but I'm focusing soft tissue treatment. So my disclosure, nothing to declare. And sometimes the surgeons, orthopedic surgeons, need to face this kind of cases. A patient with an ankle fracture, with a decent wound, sometimes an open fracture with a small soft tissue defect, and sometimes the problem increases a lot. So the learning outcomes are to know the different flap options in the lower limbs, to choose the right flap according to the size of the soft tissue defect, and of course, understand the reconstruction steps. Probably this is one of the most important slides, because we need to focus in which flap we are going to choose, muscle flap, fasciocutaneous flaps in the lower limbs, and which one we are going to choose. So probably the best thing to think is in the proximal third of the tibia, we can apply the medial gastrocnemius flap, in the middle third, the soleus flap, and in the distal part, the sural flap. If the patient presents a small soft tissue defect, and in a specific situation, we can apply the posterior tibial perforated flaps. So starting with the proximal third of the tibia, this is an 18-year-old woman who suffered an open tibial fracture. Probably if all of us think how to treat her, we decided to use a nail, but she was referred to us 1 month later with this soft tissue defect. So in that moment, we need to decide to take some decisions, and we decided to perform a debridement, to take bacteriological samples, and use a vacuum assisted closure at the beginning. Then, this is a few days later, when with the result of the bacteriological samples, we decided to nail in the tibia with a cement coating nail with a specific antibiotics according to the bacteria, and during the same procedure, to fix and to cover the soft tissue defect. In this opportunity, we decided to use a medial gastrocnemius flap. In order to increase the large of the flap, I made some incisions in the fascia. This is the medial view, and this is the lateral view, how the flap reached the lateral side. A few days later, with a good clinical condition, I applied split thickness skin graft, and with a good result. Other case, this is a 72-year-old woman. She suffered for rheumatoid arthritis, and she was treated with several prostheses in all her body. But in this particular case, she suffered a periprosthetic fracture around the knee. This is the scan, and this is soft tissue condition when she arrived at the hospital. So we decided to fix the fracture with 2 plates with minimal invasive techniques, according to minimize the soft tissue damage. But 1 month later, she returned to this soft tissue condition. So, which we can do in this situation? Well, we decided to, at first, perform a debridement and irrigation, of course, took bacteriological samples, and apply a vacuum assisted closure. And well, just only 1 month from the surgery to that situation. So we decided to keep the implants in the site and cover the soft tissue defect. So which flap we can apply? Of course, from the medial side, we can use the medial gastrocnemius flap, but in the lateral side, we decided to use the lateral gastrocnemius flap. So both gastrocnemius. This is when I harvested the lateral gastrocnemius flap, covering the soft tissue defect in the lateral side, and the same procedure in the medial side. So we apply both gastrocnemius flap. Then, with good conditions, we apply skin graft, and this is the result after 1 month without any kind of problem. And this not the same situation, but this is a 77-year-old man who suffered prosthesis infection. So the knee surgeon decided to remove the prosthesis and apply a cement spacer, but the patient developed a small soft tissue defect in the anterior aspect of his tibia. So in this situation, I thought that probably a metatarsus flap not be the best option. Reason that I decided with my Doppler find the perforators in the posterior tibial artery and the anterior tibial artery, and finally I decided to harvest the flap from the posterior tibial artery. This is a fascioscutellaneum flap. This is the image of the lateral and medial side view. And this is the flap when I harvested from distal to proximal using the perforator as a pivot point. And the flap is rotated as a propeller, and that's the name, propeller flaps. And the flap reached the soft tissue defect. And this is a video showing that situation. And the most important thing is, if the flap failed as a plan A, we can use plan B, the metatarsus flap. This is the post-op, and this is the result 1 year later. In the middle third of the tibia, of course, we can use the soleus flap, the muscle flap. This is a case, a 23 years old man who suffered an open tibial fracture, of course, with a not soft tissue defect at the beginning. He was treated with 2 pins, stabilized the fracture, and he was referred to us 3 or 4 days later. This was the clinical condition. The wound was closed under tension, 2 pins in that situation. So we decided to perform irrigation and debridement, stabilize the fracture with an external fixator. We remove also some piece of bone, free bones. And a few days later, we performed the surgery. We fixed the fracture with an intramedullary nail, and of course the ankle fracture with a plate. But the patient present worse situation in his skin, reason that we decided to remove all the necrotic tissue and apply a soleus flap. In this situation, I amplified the incision. I harvested the hemisoleus flap from distal to proximal. This is the muscle, and when I rotated the muscle covering the whole bone, then I closed the wound. And a few days later, because I don't like to use skin graft immediately, but it is possible. In this case, after a few days, I covered the muscle with a splint thickness skin graft, and this is the result after several months. Good clinical conditions. And this interesting case, this is a 24-year-old patient who suffered a gunshot in his tibia. He was treated with a nail. It's my case, so it's horrible what I did, but sometimes we can improve the situation. But this is the soft tissues condition. The soft tissues defect was really small, so I decided to apply the same flap, I mean the posterior tibial perforator flap. The red dots are the perforator, and I harvested the flap from distal to proximal. I rotated the flap 45 degrees, reaching the soft tissue defect, and then I closed the donor side primarily with a good clinical and cosmetic result. And thanks God, the bone healed. So finally, in the distal part of the tibia, we can apply the super flap. There are not any kind of muscle that we can use properly in that area. And of course, the posterior tibial flap can be applied. This is a 27-year-old man who suffered not a pilon fracture also, not only a pilon fracture, if not, he suffered a pelvis fracture, humerus fracture. So he was a polytraumatism patient. He was referred to us 1 month later with this soft tissues condition, with a soft tissue defect in the middle aspect of his ankle, but also with a pressure sore in his heel. So the patient presented two soft tissue defects, and I needed to cover both. And I think a lot, and finally, I decided to perform a sural flap. But in this case, when I rotated the flap, I cut or I split the skin powder of the flap in two pieces to cover both soft tissues defect. This is the post-op when we decided to fix the fracture. Of course, was horrible. So finally, the patient was treated with ankle arthrodesis, and this is the result after several years with a good clinical conditions. Then this is an interesting case because this is a 59 years old patient who suffered an open tibial fracture. In that time, the resident called me on Saturday and said, well, I have a patient with an open fracture. And he said, the patient present a Gustilo 3A fracture. Okay, that's okay. But when the patient was took to the OR and after the debridement, the patient presented a 3B Gustilo classification fracture. So to cover this soft tissue defect, I thought again in the middle third of the tibia to apply the sural flap, but I returned, sorry. If you can watch the X-ray, you can see that the fibula present two fractures, a double fracture, and the sural flap is fed by the peroneal artery. So I suspect that maybe this artery was damaged, so I cannot use the sural flap. So on Saturday, the angiogram was confirmed, and I'm lucky because the peroneal artery was damaged. Reason that I should change my strategy in that situation. On Monday, I took the patient to the OR. I identify with the Doppler the perforator from the posterior tibial artery. I remove the X-fix. I fix the fracture with an intramedullary nail, and then during the same procedure, I harvested the posterior tibial flap from proximal to distal. I rotated the flap 90 degrees, and then I closed the donor side, not perfectly, but this is the X-ray in the post-op, the bone heal, and this is the soft tissue condition after 8 months with a good clinical condition and not infection. And this is the last case. I also perform microvascular procedures. I'm an orthopedic surgeon, but I'm training in this area. This is a 16 years old patient who suffered an open fracture, and he was referred to her 1 month later. And the big issue here is that the patient presented a bone exposure, but tendon exposure. So I need to cover both tissues. Sometimes the muscle flap is better for the bone, but the fasciocutaneous flap is better for the tendons to allow the movement. So which flap can be applied in this situation and in a local situation? I can do that. So I decided to harvest it a microvascular flap from the thigh. This is the X-ray. Interesting case because if you can watch the X-ray, not only present a tibial fracture, if not a fibular fracture with a syndesmosis injury. So in this case, we decided to use a cement coating nail. In this particular case, it's a humerus nail because the canal of the tibia was very narrow. And after that, we fixed the fibula, and this is the clinical condition. I harvested the ALT flap. This is an anterior lateral thigh flap. And this is a chimeric flap because I could harvest the fasciocutaneous tissue to cover the tendons, muscle tissue from the vastus lateralis, and this is in the leg, the fasciocutaneous tissue, the muscle tissue covering the bone, and this is the result in the post-op with good clinical condition after several days. But the patient presented, he's 16 years old, so the cosmetics problems was important to him. Reason that I decided to debulk the flap, resecting part of them. And this is cosmetic result after a few days. So to take home, choose the adequate flap to accord the localization. In the proximal third of the tibia, you can use the middle gastromembrane flap. In the middle third, you can apply the muscle soleus flap, and in the distal part, the sural flap. Of course, in all tibia, you can use the posterior tibia preferred flap. The soft tissue defect is really small. And probably with all these flaps, you can cover the 95% of the soft tissue defect. And this is important. You need to fix the fracture as soon as possible and to cover the soft tissue defect, and thinking in an orthoplastic situation. Thank you very much for your attention.
Well, Guido, thank you a lot. You know, this is very interesting to me. I am a shoulder and elbow surgeon who does a lot of upper limb trauma, but hopefully we don't have all of these big problems when we are dealing with upper limb. But this is a very interesting thing. There are some messages here and some questions that I would like to ask you. And then we can listen to the panelists, even because all of the other panelists, they understand much more than me about that. The first issue is that it's interesting for us to understand that you don't have to be a plastic surgeon or a hand surgeon trained in microsurgery to do all of these issues. Yeah, because you're, as you said, you are not a plastic surgeon. So it's interesting that with adequate training, an orthopedic surgeon, skilled as you are, of course, can do all of these things, which are, I would say, quite challenging for sure. One thing that I would like to ask you is this. It's interesting that in these big soft tissue defects, you really like it. You really like to use intramedullary devices, because I learned it when I was in my orthopedic residency about 15, 16 years ago, maybe a little bit more, that when you have these big defects, sometimes not only external fixators are quite welcome, but even the role of Ilizarov, which is a nice thing to think about in these complicated issues. So what do you think about using Ilizarov in these very complex cases with big wounds? Do you think in your practice, do you have a role for that, or basically only intramedullary devices?
Okay, that's a good question, really. I think that it depends on your training and how you think that is the best treatment. If you are a good surgeon applying Ilizarov techniques, it's wonderful, but I'm not a good surgeon applying this kind of devices, really. And in my mind, I think the sharp fracture, the best treatment in my mind is intramedullary ligament. So I need to use that. If the patient is presenting an infection, probably I can cement the nail according to allowed some kind of antibiotics in the area. And of course, the soft tissue defect must be covered. Of course, you can use other kind of techniques. Sometimes you can short you can remove part of the bone, short the leg, and then apply an external fixator, and you lengthening the leg. And some people, probably Hélio, has more experience than me, but I cannot do that. I'm not experienced. I have no experience to do that.
No. Oh, yeah, it's very interesting, because I'm just telling you what I've been seeing a lot of time. You see, many times when I see, in between all of us, I am the guy who has less experience with that, of course. But when you have big defects, I would say with infected bone, one technique that I have seen is to take all of this infection out, and you can make some transportation with Ilizarov from down to up, and sometimes, I guess, from up to down. in a way that's something that really works. But it's interesting to see that we can manage that with in a different way. And my other question to you, Guido, is this. What do you think about in these cases, as long as we have the resources of hyperbaric chamber? I think that this is a good question too. La cámara hiperbárica.
Sorry, say again. Okay. Yes, I understood. I don't know. I have no experience. But I think if you have a huge soft tissue defect, you can use it, but the bone is exposed, you need to cover. So probably with a small soft tissue defect or some cases, specific cases, maybe you can use it, but I have no experience really.
Okay, good. And what about doing in these cases, when you do all of these complex grafts, musculocutaneous, do you do a lot of second looks on a regular basis? This is another good question. Okay, how to do the follow-up, second look, and I would say after 48 hours or after 5 days. Do you have any guidance? Because see, we have many juniors watching us, and we can. I'm not. I don't want to be narrow-minded, but if we can give some, I would say some numbers that could be interesting in the management, in the post-op management of these complex musculocutaneous grafts.
Okay, in my opinion, the best important thing is there are open fractures. So you need to stabilize the fracture with the X-fix at the beginning, if you can. If you can use a hardware better situation, but I never apply any kind of flap if I'm not sure about the soft tissues condition. So that means I perform several debridements according to be sure that the soft tissues are okay. So maybe I perform 2, 3 sometimes in the same week. So Monday, Thursday, or Saturday, I perform a debridement just only in order to be sure that I can cover with a soft tissues. I can cover the soft tissue defect with a flap with a good result. If there is an infection, if the infection is not under control, that is a problem. So you need to be sure about that.
Definitely, and these are patients who are supposed to be hospitalized for a lot of time. I guess they have to stay in hospital for a lot of time, huh?
Yes, that's true. That's true.
Okay, Dr. Robinho, Dr. Robinson, your thoughts about these complex situations, and then I want to listen to all of you guys, because see, all of these complex soft tissue wounds, they are very common in India. I know that. I've been there a lot of times. And the older I get, Guido, the older I get, even being an upper limb surgeon, I realize that all fracture management is a soft tissue procedure. Yeah, all fracture management. It's not only a bone issue, but it's a soft tissue procedure. So we are talking about the tibia, we are talking about inferior limb, but this is very common, not exactly in my practice, but in Robinho, your thoughts about this?
Perfect. Thanks, Sergio. I know Guido very well. Guido is a great friend of mine, and I am always learning from him. And first of all, congratulations, Guido. Outstanding presentation, beautiful cases. Always thinking out of the box in terms of soft tissues reconstruction. And I'd like to ask you about your experience when dealing with paraplegic patients with soft tissues defects around the pelvis, because you have a paper about that. And I'd like to know how did you start doing soft tissues reconstruction around the pelvis? Because this is not familiar for us orthopedic surgeons, no?
Yeah.
Okay, thank you for your kind introduction. Well, Sergio said before, the big issue here, the plastic surgeon in my hospital just only perform cosmetic surgery. They don't care about those kinds of tissue defects. So I needed to focus to cover soft tissue defect. Of course, it's around the pelvis, and I need to take care about that. So I started to learn at the beginning, read, then learn from other surgeons, not in my hospitals, in other places. And finally, in around the pelvis, just only you apply local flaps. So to perform this kind of flap is easier than in the leg, really. I know that probably at the beginning you need to learn, but it's just only mark the flap with dots, and that's all. Just only cut there. So I don't know how to say, really. It's interesting topic, but
it's not hard. You need a learning curve. But
exactly, and I couldn't. I can't show you cases about that, because I thought that probably was a problem, jumping from the pelvis to the leg. So, and in the middle of the thigh, usually you have not any kind of problem, because the soft tissue, it's good enough. So.
Okay, Guido, thank you very much.
Yeah.
No, thank you.
Very challenging cases. But I would like to listen to the other panelists about their experiences with these open wounds in the tibia. Dr. Hélio, your thoughts, because Dr. Hélio has a lot of experience with this. I follow his beautiful work. If you want to talk, we are seeing different views of dealing. Yeah, there are many ways to skin a cat. But if you want to talk just a little, Hélio, about when you have these big defects, if you remove them, if you do some transportation, I would say your rationale on these complex issues, on the tibia, which you'll deal a lot with.
I believe that as a primary option of treatment, the fix and flap is the best option for the patient. Yeah. My experience, I tend to treat more infected patients. So I usually do the transportation with even open transportations. But if I would treat myself in a situation where I have a big exposition, I would prefer to do the fix and flap. I have to congratulate Guido, because there are really nice cases, and I wish I could do that kind of thing.
Yeah, it's beautiful, because you see, Guido, what a difference it makes when you know how to deal with soft tissue. Yeah, this is a message for the young orthopedic surgeons, that orthopedics on I would say an utmost level implicates much more than passing nails or doing screws, but to have a very good understanding of the soft tissue coverage. But Dr. Wasudeo, I know that you, sir, you do a lot with complex cases in your place. Your rationale about these difficult scenarios, sir.
Guido, your excellent presentation and excellent cases. There is no doubt about it. But you have shown only the positive response of your surgery. There are three questions that I will ask you. One is, what is the percentage of failure of surgery? One. Second is, when you change the external fixator to a definitive, what is the interval between the two procedures or on the same sitting? And third, what is the use of your negative pressure dressing? That is so rampantly now used all over the world, and the results are very good. Small defects are taken care by vac dressing. What is the take of your vac dressing, your views? And fourth, you have used the same leg flaps what about the opinion of the cross leg flags? Because sometimes it is very difficult to harvest the same limb flaps, and there are so many defects are there. Sometimes we also take the help of the other leg, a cross flip flap. So there are 4 questions that I want to get answer from you.
Oh, doctor, just let me help you, Guido. Dr. Wasudeo, can you make the first question, please? And then we go slowly.
What is the percentage of failure of your cases after doing this very excellent surgery?
Oh, okay. If you think about the muscle flap, the fail is 0 because it's incredible flap. If you think in the gastrocnemius and soleus flap, I have no any kind of fail. Sural flap, it's different, and there are 2 kind of population, youngest or older people. But the percentage is approximately 15% talking about the sural flap. According to the literature, it's the same. People who smoke, people who have any kind of vascular disease, probably the flap failed, probably more probably fail than in younger people.
Yeah, but it's quite logical what you have said. When people smoke, the prognosis probably is not so nice, Guido. And when you have diabetes or I would say another vascular
some kind of comorbidities.
Yeah. Okay, doctor. Yeah. No, I'm listening to you.
No. That's all. If you think this patient it's a young patient and in a traumatic situation, it's the best situation. In the other side, comorbidities plus old people, probably you have more kind of problems.
Lovely, Dr. Gadegone.
Yes.
Do you want to make any comments before doing your second question, sir?
No, this is good that he has a very good success, but it in practice I find even probably this is the host factor also is responsible for success of these flaps. So probably Guido is a very lucky man, he gets 100% result. But in my observation, there are some failures are there. So next question is, what is the interval between changing of your primary external fixator to a definitive surgery?
This is a good question. This is a very good question. That's a good question. It depends on the case. If the patient was referred 1 month later, I prefer to identify the probably infection. So I perform a first debridement, and I need to be sure about which bacteria I'm treating. And if I'm going to fix the fracture with a nail, which antibiotic I'm going to use in the nail. So that takes in my hospital 5 days, probably. So maybe 1 week in average, maybe less.
Yeah, you know,
it's an acute fracture. Just only 1 debridement. I perform the second one, and if in the second one the soft tissues are okay, I perform the procedure, the final procedure.
Yeah, I was expecting you to say, I would say 4 days or 5 days, not more than 1 week. But it depends on the case. I know it's you don't have to think only about the bone. You have to think about all of the soft tissue coverage. This is something, you know, it's very different from the upper limb, in which the soft tissue problems is not exactly what tell us what to do. But well, that's and then Dr. Wasudeo, he was asking you about the cross leg, which is something very Dr. Gadegone.
Yes. There are again whether they use up a cross leg flap. Sometimes it is very difficult to harvest from the same leg the flap. Do we use sometime a cross leg flap in a distal tibial fractures?
Yes, I think that is a wonderful option. Before I put the patient, of course, and I apply this particular procedure when the patient, for example, is suffering he has a vascular injury. Maybe the patient has only one artery. I need to perform a microvascular flap with anastomosis, lateral anastomosis. So I'm not sure if I'm going to have success. So in this particular case, I use this kind of flap. I think these are incredible techniques nowadays.
Okay, very challenging cases. And Guido, one question. I'm just curious. I know it's a very difficult, I would say, question, but the thing is, what's the rationale to ask for an arteriography? You know, I know it's a difficult one, but I saw you made an arteriography. So when would you ask for this? I would say this kind of I would say investigation.
It's an excellent question. Probably it depends on several things. First one, where is the soft tissues defect? So where is the fracture? In the case that I showed you before, I thought to perform a sural flap. The patient presented a double fracture in the fibula. So I suspect that maybe we have a problem with this case. In other cases, I failed because the patient presented a pilon fracture. I applied a sural flap, but the patient presented some kind of comorbidities. Because when the patient suffers a fracture, I don't know if present an injury of posterior tibial artery, anterior tibial artery, I don't know. So when I perform microvascular procedures, I usually perform this kind of angiogram, just only to know where I'm going to fix my flap or where I'm going to perform the anastomosis. In the local flaps, probably in the muscle flap, I don't need it. In a sural flap or in the distal part of the flap, in patients with comorbidity, I try to discover if he present or the patient present any kind of artery problems. Nowadays, I can use angio-TC.
Okay.
Do you know? I don't know in English. How is it in English?
No, it's angiotomography. Yes, it's angiotomography. That's it.
Okay. Nowadays, I can use that.
Yeah.
But the best option is the angiogram.
Okay. You mean the arteriography?
The arteriography. Yes, it's the best study to know about the soft tissue damage, and sometimes not only as a diagnosis, as a treatment, because the guy who performed the angiography can fix some problem with stents.
Yeah, it's like a stent, like in the heart. Something like that.
Exactly.
Okay. Dr. Gadegone, any more questions?
Yes, last question is, in this type of very devastating injuries, do you use a VAC, negative pressure VAC, because the small wounds, they heal by VAC and you don't need a plastic cover like a flap or cross-flake plate. So what is your take on negative pressure therapy?
On negative pressure. I've been listening a lot about that. That's another good question, Dr. Guido.
So in my mind, but I know that I have some experience to perform flaps. So in my mind, the negative pressure must be used just only as a dressing. I applied just only for a few days. That's all. If the patient presents a soft tissue defect, I move to fix the problem with a flap. Okay. I don't like it to use a vacuum assisted closure as much a few days. That's all.
Or initial period you use it.
Sorry?
or initial period for you use the vac. That's all.
Yes. It's a wonderful tool. Just only for a few days, but yes, I use it.
Okay,
but it's not the commercial assisted closure. Just only I connect the patient with a negative pressure in the wall of in the hospital, in the room.
Mm-hmm. Okay, Guido, I have a last question. I saw that you like to do that technique with small cuts in the skin graft, which is called the pie crush. You know,
yes.
You make, yeah, small cuts in the skin graft. I learned that is very good in order to diminish, I would say, the tension on the skin. Do you do this on a regular basis? Because I learned it with hand surgeons that this is very important.
Yes, I do always. The point is two things. The first one, you can increase the size of the
Sure.
skin.
Sure.
And I have not the mesh machine, so I use just on the scalp. And on the other hand, it's you avoid the hematoma between the muscle and the skin, in order to decrease the necrosis of the skin, to fail the skin graft. So that's the reason.
Okay, and my last question, do you know that technique with the Blair, la faca de Blair, the Blair knife, to take some skins from the anterior part of the thigh, of the femur, the anterior thigh? Because my last question is, when you have big problems with the tibia, where do you think about picking up skin free grafts from the thigh? I would say with a Blair, Blair knife. This is a very good point too.
Excellent question. It depends. If I think as an orthopedic surgeon, and it's easier for us to pick it up the skin from the same thigh. Okay. But if the patient, for example, I'm not sure the patient is going to be amputated in the future because the injury is so high that I'm not sure. In order to leave a good soft tissues condition in the thigh, sometimes I pick it from the other side.
Mm-hmm. Okay. Well, these are complex cases, I know, but it's very interesting to see all of this, because I would say the soft tissues, they are as important as the bony issues to determine the final outcomes and the prognosis. Okay, so before we go to Dr. Wasudeo's lecture, Dr. Wasudeo, any other questions to Dr. Guido? I know you, Dr. Wasudeo, you deal a lot with these complex wounds. So if you want to ask, sir, Dr. Guido, any other stuff, sir?
Yeah. Guido, sir, if you fail this procedure, and if there is a rampant infection inside intramedullary, and it is possible that if dealing with a compound fractures, you have done a nailing, you have done a soft tissue procedure, still there is a lingering problem of infection, there is a discharging sinuses, and flap does not take well. In a such situation, whether you refer this patient to your Ilizarov person, or you again repeat the same procedure and for the benefit of the patient.
Yeah, he means, Dr. Guido, when you have a sinus and pus coming out from an infected tibia with an intramedullary device, your concerns about taking all of that out and putting an Ilizarov. I learned that in my residency a lot. It's another good question.
Okay, if the patient is presenting an infection, it's depends with what kind of infection. Maybe it's an intramedullary infection, that's only to perform a debridement of the canal. If the bone is infected in around the fracture, maybe it's true, I need to resect this part of bone, maybe I use an intermediary nail, a new one, with a same spacer in this area, and I cover the soft tissue defect with a flap. And maybe 1 month, 2 months later, I perform a lengthening with that, but I don't use Ilizarov. I use OrthoFix, a monoplanar external fixator. But if the patient is suffering an infection, you need to control infection. If the problem is the bone, you need to resect it. If you have experience with Ilizarov, it's wonderful. I have not experience. I use monoplanar X-Fix.
You mean the monoplanar?
Monoplanar, exactly. Yeah, OrthoFix, the OrthoFix flap.
Okay.
The OrthoFix, the monoplanar.
Okay. My last question, Dr. Hélio, are you there? Dr. Hélio?
Yeah, I'm here.
Yeah, lovely.
Shoot.
No shooting. The thing is, Dr. Hélio, what do you think about the last point Dr. Guido has said about dealing with the monoplanar fixator in spite of the Ilizarov? This is a good question because Dr. Hélio is a master of Ilizarov, but there are many juniors.
Not a master.
Okay, but semi-master. It's going to be a master. But the thing is, there are many young surgeons listening to us in India who can do, I would say, not an Ilizarov, but a monoplanar device. So any concerns of using, like Dr. Guido said, an OrthoFix monoplanar device instead of Ilizarov itself to deal with these challenging scenarios? This is a good question.
It's a good option. I usually don't use for reconstruction. I believe the linear, the LRS, linear ring reconstruction, is a good option, but it's a bit limited. It's a good way to fix a primary fracture, a shaft fracture, but on complex cases, I would use a circular, not Ilizarov. I would use Exapod or a Taylor if it's available, but linear, the monoplanar fixators are a little limited. I usually don't use it in complex cases.
Okay. Dr. Gadegone, any final concerns about this before you start your lecture, sir?
So it's a wonderful topic, and we have he has answered all the questions.
Okay, so Guido, thanks a lot to share with us these difficult scenarios. I'm learning a lot. And so now let's move to Dr. Well, now we are going to talk a little bit more about my world, which is the upper limb. So just for people to understand, Dr. Gadegone, he has, I would say, developed some interesting devices about intramedullary nailing of clavicles, of the humerus, with very cheap and affordable devices. This is very interesting to me, for all of us, for sure. And I'm gonna just reinforce that when describing the technique, Dr. Gadegone is gonna go a little bit slower for everybody to understand the steps. So, sir, I'm very curious about your lecture, sir. You can start. This is very nice.
So, good evening, and here in India, and good morning at your place. Thank you, Sergio, for giving me the opportunity to deliver my lecture for the benefit of younger surgeons. And these are all cost-effective surgeries in the fractures of the clavicle and diphygeal fractures of the humerus. So, you know, all year 20 and 21 will remain as the most special and unforgettable year in the life of human mankind and medical fraternity because of COVID-19 infection. So this is the I welcome all faculties, Hélio, Guido, Robinson, and a convener, Dr. Sergio, Rowinski, for Unconventional Orthopedic Trauma, Amplifying the Limits of the Possible. So my presentation is dedicated to poor people who cannot afford the mainstream treatment and still deserves a good quality functional outcome with affordable cost. I changed my thought process. I had to modify my learning in the orthopedics to suit the need of the poor. Innovation in implants, lateral thinking, awareness, jugaad in limited budget and infrastructure. I am sharing my biological methods of fracture fixation of mid-clavicle and humeral shaft fractures, which can be executed at smaller place with equally comparable result with current fixation methods. Mid-clavicle fracture in adults, most of the fractures clavicle will heal by non-operative treatment. Fracture clavicle middle third, is it still a virgin area in orthopedic for surgical treatment? Answer. The current literature, surgical stabilization with either plates or IM device should be the preferred treatment option for these more complex and mid-clavicular fracture. Surgical treatment of clavicle fracture is advised in widely displaced mid-shaft fractures, multiple trauma, displaced distal third fractures, open fracture associated with neurovascular injuries. Displacement and bony overlap more than 2 centimeters, skin under jeopardy, and comminuted fracture, fixation is indicated. Decision whether to operate or conserve. If you get such a fracture, comminuted fracture in a young man, and current literature says that you can treat this fracture by a closed or by a surgical methods. But we have to think not only the displacement of the fracture as a whole, but the patient history to understand his or her activity level, functional demands and expectation, and early return to work. So minimally invasive intramedullary nailing of mid-shaft clavicular fracture using titanium elastic nail or RF by anatomical precontricular clavicle plate. Excellent methods and they give equally good results. No difference between nails and plates in the terms of healing and outcome. Why big debate whether to use nail or plate? It's because plate fixation, it's an open surgery, ugly scar, hardware prominence, plate breakage, dysthenia in the region of the scar. It's the most uncomfortable thing because of the injury to the supraclavicular nerves. Meta-analysis of plate fixation versus intramedullary fixation for the fractures of the mid-shaft clavicle fracture. Conclusion. The present evidence from this meta-analysis, intramedullary nailing was a more advantageous method for the treatment of these displaced clavicle fractures. Now, elastic stable intramedullary nailing compared with the non-operative treatment of displaced clavicle fractures, 30-30 patients. Union was in non-operative patient 90% union, 100% union by elastic nail. But see the complication, 7 cases medial nail protrusion and 2 refracture after removal of the implant. Rest, the functional outcome is the best after operative treatment. Minimally invasive IM nailing using titanium elastic nails. Major problem is medial migration and lateral perforation before union. Other methods of fixation like Rakut intramedullary pin of clavicle fracture. This is also a open reduction and pin fixation. McKeever intramedullary fixation of a clavicle fracture, which is from the other side. Good functional outcome is reported. Migration problem is solved with interlock nailing of the fracture clavicle. Technically demanding procedure, and it's not available to my patients. Hence, I devised a new concept in the treatment of the clavicle fractures with the screw intramedullary nail, typically inserted from medial to lateral side, can be used in a comminuted fractures because textbook says comminuted fractures plating is the preferred treatment. Small incision at the fracture site may be needed sometimes if you are not able to reduce the fracture by closed methods. How I do it, and screw intramedullary, what I use it. It is a 5 to 6 centimeter in length, 2.5 to 3 mm in diameter. Screw portion is 10 mm in length and 4 to 5 mm, 4.5 mm in diameter, and screw hole of 3.5 mm so that it can be screwed in the clavicle with the 3.5 mm screwdriver. How I do it? Supine position, 1 to 2 centimeter in length incision just lateral to the sternoclavicular joint anteriorly. Blunt dissection to expose the entry point of the nail. Window near the sternoclavicular joint, entry point marking. Bone hole is passed and entry point is enlarged. Assessment of the length and diameter of the clavicle is must before you start the surgery. Otherwise, you will not be able to do a nailing. If you are not able to pass more than 2 mm nail, it is better to do a open reduction and plating, because below less than 2 mm diameter nail will not sustain the forces of the shoulder girdle. We must study the deforming forces so that you can reduce by closed methods. Pushing of the shoulder upward help to reduce the lateral fragment to medial fragment, and you can also take the help of a towel clip in closed reduction and manipulation. Reaming of the canal is very important. It's because we have to use a flexible reamers. Unless you ream the medial fragment, you will not be able to pass the nail by hand. Otherwise, it will have to hammer and probably it will stuck at some place. So medial fragment must be reamed by a reamers. They are available. So if you ream by 2.5 mm, use a 2 mm nail. If you use a 3 mm, you can use a 2.5 mm nail. More than that is not required in the clavicle. Reduction of the fracture with the help of towel clip, as I said, and then after reaming, you have to pass a nail or negotiate the nail at the fracture site. You can take the help of the 2 towel clips with the assistant so that he will align the fracture fragment in proper position. You can see here, and then it is just negotiated in the opposite cortex. Once you are perforated the opposite intramedullary canal, then probably you get the stable feeling and the reduction is achieved, and you can then slowly push the nail inside the distal fragment. Negotiation of nail through the fracture site, and you can see here, you can do a screwing because it's elastic nail. It takes the shape of the clavicle, and the placement of the nail should be up to the solid portion of the or flat bone of the clavicle. This is a very crucial stage. Monitor every step in the C-arm, otherwise you may damage the underlying neurovascular structure where breathing spread is only up at 10 mm. So it is very important. And if you are not able to do a close reduction and possibly not able to negotiate the nail, in the next fragment, give a very small incision and just inside the nail. Now this is the example, a mid-clavicle fracture with a butterfly fragment in a 28-year female. You can see here, the nailing is done close, mostly a one stitch or a stitchless surgery, and the fracture has healed proper. Another example, a comminuted fractures, close nailing, entry point marking, bone hole insertion. Comminuted fracture, both the ends are fixed by screw medial end and lateral end into the solid portion and flat portion of the clavicle. 3 years of follow-up, no migration, scarless surgery with a full function. 3-point fixation, relative stability, achieved medially with the screw and distally with the impaction in the solid bone and at the apex of the curvature of the clavicle. So it is not a rigid fixation, but it helps in keeping the fracture fragment together, and also it helps in nullifying the deforming forces, relative stability, good healing by callus formation. Another example, a mid-clavicle fracture with comminution, 30-year male, healing of fracture by a callus formation. Just we have to put the nail inside, 3-point fixation and curved bone, straight nail. It takes the shape of the clavicle, it heals. Grass overriding with displacement, difficult to obtain a close reduction. We tried it, first trying the close reduction, and if it is not possible, then go for a small incision, open reduction in the irreducible fracture and insertion of the nail. Sometimes it is possible that the medullary cavity of the distal fragment is very, very narrow. In that scenario, probably open it and do a reaming of the distal fragment also, so that the nail will fit into the flat bone of the clavicle. Placement of the screw in a cancellous bone of the clavicle which prevents medial migration, and placement of the tip of the nail in a flat bone which prevents lateral migration. Displacement of fracture with a butterfly fragment in a 32-year male. If there is a difficulty, give a small incision to access the fracture fragment. Mini open reduction, 1 or 2 stitches, early overhead exercises without pain. 2 months follow-up, patient is able to do all activities. Displaced fracture in 80-year-old male with a wide canal. Sometimes it is possible in an old osteoporotic bone. Grossly displaced fracture fixed by a screw intramedullary nail with additional stacking of the nail, so that the filling of the medullary canal, 3-point fixation, and you can see restoration of the anatomy, good functional outcome, wide medullary canal, rotationally unstable, hence stacking is done. Another segmental fracture of the clavicle, apex of the fracture irritating the skin, and therefore it needed surgery. Segmental fracture, perfect healing and restoration of the function by close technique. Clavicle malunion, symptoms of pain, fatigue, cosmetic deformity. It's a relative indications for surgery, but this type of a scenario, patient routinely they come for follow-up after 1 month or 2 months. Majority will tolerate this type of a deformity and there is no need of a surgery. But in a demanding patient and those who are having symptoms, surgery must be done and anatomy must be restored. 1 year of follow-up, full function, excellent callus formation inferiorly without bone grafting. Another example, a grass displaced clavicle fracture with skin puckering. This needs surgical intervention. Difficult close reduction, hence open reduction and screw intramedullary fixation was done. and 18 months follow-up, a full function, perfect anatomical restoration and union. Another grossly displaced 2-month-old fracture. Sometimes it is possible, people, you can see there is a puckering of the skin, open reduction and screw intramedullary fixation done, a small incision and restoration of the anatomy. Ipsilateral displaced fracture of the clavicle and humerus diaphysis, close reduction, intramedullary fixation of the shaft, minimal invasive surgery, 2-stitch surgery for humerus and 2-stitch surgery for a clavicle. Take home messages. Consistent achievement of union and low frequency of complication with screw intramedullary nail. Screw nail, cost-effective, minimally invasive surgery with excellent results. Nail migration is prevented by screw and jamming the nail into the flat bone of the clavicle. Spares nerve, which is very concerned after the plating, and he saves the money because it's very cost effective, and the plate, anatomical plates may not be available at all places. So another, should I continue, Sergio? Sergio. So
yes,
another,
sir. No.
Yes, I
yes,
continue.
sir. No. You can show your elastic intramedullary nailing, and then we will discuss.
Yes,
I have a lot of things.
So I will continue. So now, yes, I will continue. So this is another presentation of me, an elastic intramedullary rust pinning in the treatment of fracture, diaphyseal humerus fractures. Humerus shaft fracture, majority treated by conservative treatment, what is literature said, but probably majority people now, the humerus fracture is operated. Excellent clinical results could be obtained with non-operative care. There are number of articles and famous article from Sarmiento et al. That functional cast gives equally good results. In modern era, with the optimal condition of the patient, surgeon and instrument, internal fixation gives best results. Fixation of humerus shaft fracture, cross view, interlocking nailing so popular in femur and tibia, not in humerus, because there is no consensus and not recommended as a standard method of management for humeral diaphyseal fracture as against plating. Problems of rotator cuff injury and shoulder stiffness after antegrade nail insertion. Reported complications of healing problems, infection and iatrogenic radial nerve palsy after plate, though plating is a preferred method. I am sharing cost-effective and easiest method of stabilization of diaphyseal humerus fracture by elastic intramedullary rust pinning by closed method, sparing rotator cuff entry, surgeon and patient friendly and biological fixation. Now take an example of a 23-year male with a distal comminuted fracture. Treatment plan is not standard. Some may do a conservative, some may operate, some may do nailing, some may do plating. So there is no enormity amongst the orthopedic surgeons. Depends on surgeon's preference and patient's expectation. Everybody is right. Those who are doing a conservative, operative, or a willful neglect. Procedure of elastic rust nailing, surgery on the standard table under the guidance of image intensifier, position of the patient, that is pillow under the shoulder, so that we can anteriorly, we have to lift the shoulder, humerus, so that entry points becomes very easy. Attempt for the close reduction, we have to see in the Shyam. Now this is a highly comminuted distal 1/3 humerus fracture. You can see this was the initial picture. You will find in the second picture, there is some alignment is seen in AP and lateral after close reduction. Feel the end of the acromion and greater tuberosity, make a small incision of 1 to 2 centimeter, very small incision. Entry point was at the greater tuberosity, just lateral to the insertion of the supraspinatus tendon, after splitting the deltoid in line of its fibers. Pass a 2 or 3 mm pre-bent reduction nail and confirm the reduction on C-arm. So first nail passing is very important because it is going to realign your fracture. Negotiate the nail across the fracture site till the tip anchors into the distal metaphysis. How it will anchor? Because the nail tip is beveled and it is sharp, so that it will stick into the solid portion of the distal humerus. Fill the medullary cavity with rust nails of unequal length and in the size ranging from 2 to 3 mm. It's because the proximal, middle and distal canal is variable. Therefore, if you want to fill the canal, you cannot pass only 3 mm, 6 mm. We have to pass sometime 8 mm in the proximal fragment, 7 mm probably in the middle fragment, and 6 mm in the distal fragment. Therefore, if you want to pass nails of 2 to 3 mm, it should be a variable length and a variable diameter. That is the crux, and they must go up to the Allecran fossa. Burying up the nail in the proximal humerus to minimize the impingement and in distal metastasis to impart the stability. Avoid distraction and rotation. That is the most important thing. Non-union cause is the distraction. It should be distraction should be avoided. Avoid damage to the rotator cuff. And third most important point, after finishing your surgery, you try to rotate the humerus and check into the C-arm. If there are no rotational movement at the fracture site, then and then it is your fixation is stable. Otherwise, you have to negotiate another small nail to jam the fracture site. After complete impaction of the proximal end, abduct the limb to confirm that nail is not coming in the way of abduction. Strapping for 3 weeks. Active exercises and passive exercises, overhead exercises after clinical and radiological progress of the UTM. There is a apprehension of the distraction as humerus is a hanging bone and subject to gravitational forces. So don't apply a plaster cast. It will, with the gravitation, there will be a distraction. This can be managed simply by post-operatively giving a humerus an adhesive plaster immobilization of shoulder and elbow and do a physiotherapy of shoulder and elbow in a particular motion, providing a hydraulic effect through the biceps and triceps contractions. For example, a placed osteosynthesis of a comminuted humeral fracture is a challenging operation, requires a surgical experience, meticulous dissection to periosteum, muscles, and nerves, minimal invasive surgery, multiple elastic rust nails, follow-up after 1 month, 3-point fixation without disturbing the osteoperiosteal sleeve of a loose fragments after 1 year of follow-up, biological stable fixation, union, and full function. Just forget about the loose fragment. Try to stabilize the proximal and distal fragment. Rest of the fragment, they will fall in place and unite. Rationally of multiple nails, one unrimmed nail does not provide enough strength and stability. Rotation of the distal fragment cannot be prevented. To overcome rotational instability, multiple rust nails jammed in the west of the medullary cavity through a cortical window, providing an efficient 3-point fixation. Example, you can see a stability achieved by filling up the medullary cavity with elastic rust nails and spreading the bunch of nail into the metaphysis. This is how it is. They are spreading at various levels into the metaphysis. And you can see here, this is a very large butterfly fragment, twisted, not disturbed at all, close, nailing, and everything healed around the nail. Another example, a transverse fracture, proximal third, plating is the gold standard because there are forces of abductors and adductors. But you can see nailing is done, perfect restoration of anatomy and healing of the fractures. Enhanced stability by multiple nails, burring of the nail proximally and distal fanning of the nail tip provides a natural internal locking. Nails of different diameter and length provide a stable internal fixation as it fills the variable cavity and fixes in the solid distal portion. What the Kunzer principle is, filling the canal with the larger size nail. Here we are filling the canal with the bunch of nails which provide strength and stability. Example, preferred treatment, as I said, a compression plate, 10 years of follow-up. You can see here, complete restoration, multiple nails, transverse fracture. Probably nobody will dare to do this type of it. But I assure you, there are n number of cases they are treated by this method. Another example, upper 1/3 shaft fracture humerus, distal third of the humeral diaphyseal fractures treated by multiple nails. 15-year female, unstable after close reduction, restoration, perfect anatomy, 5 years follow-up, everything healed around the nail with full function. Example, short oblique fracture, union and full function. Another example, a comminuted fracture, middle third, good union is progressing at the 10th week follow-up. No disturbance to the loose pieces of butterfly fragment and comminuted pieces. Only stabilization proximally and distally, filling the canal, provides enough stable fixation and the fracture heals. Another example, distal complex fracture. I have no doubt that everybody will decide to do with a double plating, medial, lateral, and probably augmented with bone grafting. Just do a multiple elastic nail as internal splint, distal planning in both planes, principle of Kunsner's and Rust mix, both 3-point fixation and filling of the canal. And you can see elastic nail can be effectively utilized, paying little respect to reduction and stable fixation of extreme distal fractures of the humerus, and this is the functional outcome. Another example, a short fragment is very unstable fracture, segmented multiple pieces. Probably it would have been used as by conservative methods also, but in modern technique, probably it will be done by a double plating technique. You can see multiple antegrade nail and one retrograde wire just to stabilize the medial fragment and healing of the fracture and full function. So this is the paper I already published in 2007. I did more than 200 cases that time. Antegrade Rust nailing of fractures of the humeral shaft, and analysis of 200 cases with an average follow-up of 1 year. This is well published in the European Journal of Orthopedics and Traumatology, and there is a reference in the Green and Rapid and Green textbook of surgery in a chapter of the humerus. This is another very interesting example. Radial nerve injury, medial butterfly fragment with a spiral fractures, Holstein-Lewis fracture, spiral fractures of the distal 1/3, 22% of incidence associated with neuropraxia of the radial nerve is reported in literature. And we find so many cases, whether to explore the nerve or do a just fixation. There always we are in dilemma as a surgeon, and the patient is also in the problem because his hand is not working because of the radial nerve. Everybody is apprehensive. In this case, stabilization of the humedial and lateral pillars with the two elastic rust nail retrograde after exploration of the nerve, clamping of the fractures. You can see here, this is I did recently multiple, you can see a very comminuted fracture, and then exploration of nerve, it was intact, post-op X-ray and clinical photograph. This is I did last week, and this is the X-ray of yesterday only. So if you restore the both the pillars, and you can see the fanning of the all four wires into the humeral head, which will prevent the rotational movement. So rotational movements are prevented proximally as well as distally, and just a small cerclage wire to keep the bony spike should not irritate again to the radial nerve. So again, we have published another paper of this technique only, multiple elastic retrograde intramedullary nailing for adult humeral diaphyseal fracture in the Journal of Orthopedic Surgery and Technique, October 2020, along with my friend Yogesh Salfale. It is an alternative and effective surgical modality along with many techniques described in the literature. My view is that it is not the only method. It is not a comparable to the plating also. It is not in competition with other methods. It can be one of the methods which can be used in the armamentarium of adult humeral diaphyseal fractures. Limitations: limited rotational and axial stability by proximal and distal fixation. I do agree. It cannot give a very perfect stable stability like a plating. Reduction and passage of nail technically difficult in a segmental and comminuted fracture. That time we have to see both AP, oblique and lateral plane to negotiate the nail. Maintaining reduction of fracture in a close proximity to metaphyseal player may be difficult, and sometimes you may require a small open reduction, clamping of the displaced fragment, and then negotiation of the nails. Complications, they do occur: non-union, broken implant, delayed union, radial nerve palsy, which it has always recovered, upward migration of the nail, and painful restriction of the shoulder. It is possible, but they are all preventable complications. Complications are comparable with any standard method, and sometimes say 3 weeks of immobilization may give problem for shoulder mobilization. But after a good physiotherapy, all my patients regained shoulder motion except few. In conclusion, it is a closed method with negligible cost to the patient. No blood transfusion, 2-stitch surgery, no infection, and biological fixation and early union. So my friend Sergio, thank you very much for giving me an opportunity to share my biological methods of clavicle fracture and humerus. I don't disagree that the plating is a standard and it is the way ahead of this method, but I can show you, and I assure you, I can give you equally a comparable result with the modern techniques that are available in the arena of this surgery. Thank you very much.
Thank you, sir. Thank you, Dr. Robinson. I will ask you to come back, Dr. Guido. Sir, beautiful presentation. I have a lot of things to ask you, and I'm gonna ask Dr. Guido too about his opinions, but I have, I would say, serious and very practical concerns about that. So I'm going to start like this, sir. These are very precious to me. The thing is, if we start to analyze clavicle fractures management from the last 15 years to now, things are changing. And Dr. Robinson, he knows a lot about that. After the Canadian study from 2007, which changed the thinking of all of these things. If we think, sir, 20 years ago, everybody would say that conservative management of midshaft clavicle fractures would be the gold standard. Everybody would say that. but things are changing after the Canadian study from 2007, which showed us that there are much more complications in conservative management than we may imagine. In my opinion, because I have an OPD in my public hospital in which I follow a lot of conservative management cases and post-operative cases. And I can tell you first that the number of pseudoarthroses that I have, it's much bigger in the cases that are not operated than in the cases that are operated, okay? And this is supported by literature. So, but the problem with the plate, sir, is that this is what I've been thinking in the last 5 or 7 years. A big scar incision, sometimes the screws, they are protruding on the skin. And if we could do something minimally invasive, that would be much probably the way. So you see, sir, what opened the doors of India to me 13 years ago was the anterior bridge plating. So the rationale would be the same. So in this sense, I see your technique on the clavicle with, I would say, as a very logical option. But I have one question, and then I would like to ask your opinion and Dr. Robinson's opinion and Dr. Guido and Dr. Hélio if they want to speak, because this is a very, I would say, the $7 million question, sir. The thing is, when I was in my residency, I learned that whenever you are doing an intramedullary device, for example, in the tibia, to make a small incision to achieve reduction was a sin, was something absolutely wrong. And people were very, I would say, harsh on this point. And the thing is that what you have done, it's to enter with the nail, and sometimes you do, I would say, a small incision, an open incision on the focus to achieve reduction. And it doesn't seem to be any major problem to me. I think that this will not be a sin, but rather than that, that would be, I would say, just part of the game when it's needed. So I would see that without major concerns. So once we have 2 AO strong faculties here, Dr. Guido, Dr. Robinson from different countries, I would like to ask them, Dr. Robinson and Dr. Guido, I'm not talking about the tibia now, I'm talking about my universe, which is the humerus and the clavicle. When you are doing an intramedullary device like these beautiful things Dr. Wasudeo has been showing us, when you do a small incision to achieve reduction, is it a sin or is it absolutely part of the game? I see as part of the game, but I would like to know your point of view about that. This is a very nice question, Dr. Robinson and Dr. Guido.
Sergio, thanks for the question. This is part of the game. If you preserve soft tissue surrounding the fracture site, this is not a major problem. And I'd like to congratulate Dr. Gadegone because I remember a sentence of Da Vinci that completely depicts this lecture. That is, simplicity is the ultimate sophistication. So this is a very, very nice lecture because cost effectiveness really matters for us, And I congratulate you to present these techniques. And if I have time, Sergio, I'd like to ask something for him.
Sure.
Is it possible?
Absolutely. No, it's absolutely possible. But again, sir, it's a beautiful technique, and what Dr. Robinson has mentioned, it's very nice in terms of cost effectiveness. And we have all of these issues in the public system here. We know that, and you know that, sir. So having said that, let's listen to Dr. Robinson's questions. But that my question to Dr. Guido, I would like him to answer too. But let's let's listen to Dr.
Go with Guido.
No, your questions first. Your questions first.
Okay. The first question is, when you have to remove the clavicle nail, is it a problem for you? Is it an issue or not? If you have a breakage of the implant, for example, or if you have a non-union and you have to change your treatment, what about the nail removal? The first question. And the second question, when I see you doing this technique in the clavicle, I was completely seeing my problem when dealing with superior pubic rami fractures of the pelvis or anterior column fractures of the pelvis, because we have straight screws and we have a curved bone. And did you think about the possibility of using this technique of the clavicle into the pelvis or not? Or I'm crazy?
No. Why? You can use it.
We are all crazy. We are all crazy. But this is a very good question, sir. You can answer, sir.
Robinson, this is a very good question. But we have to make, if you want to use it for pelvis, you can do it, increase the diameter and screw diameter. Then you can use it. There is no problem about it. Because the screw diameter and the diameter of the shaft is all custom made. For clavicle, this more than 3 mm is not advisable. It is 2.5 and 3 maximum. So that is how it is. So you can use in this, you can modify the technique and you can use in the pelvis also. There is no problem. Second problem, how to remove. It is because we are inserting the screw impacting into the soft bone of the clavicle. That is near about 1 centimeter bone at the sternoclavicular joint. It is a cancellous bone. So therefore, if you just add 4 or 5, there are actually serrations are about 10, I think so. So suppose if you keep 2 to 3 serration out, we keep 2 to 3, it is not gone inside the bone. We have to, it is in the soft tissue. So 1/4 of the nail, 1/4 of the screw, it is outside the bone. So that when you remove it, just give a small incision, because you can palpate it also. It is not visible, but if you go and palpate on and do a surface marking, probably you will be able to know that there is a screw on the bone. So this is how it is. So the removal is not an issue at all. Now,
but sir, excuse me, just a second, sir. But do you do this in all of the cases? You leave, I would say, 1/4 of the screw outside of the bone. Do you do this on a regular basis?
Yes, regularly. It has to be. It has to be. Otherwise, if it goes inside in the medullary cavity, in the soft bone, and if there is a coverage, it will be very difficult to remove. You cannot just remove it. Yes. And it is more. And then
but if you don't have to remove, doesn't it bother the patient a lot because you left a little bit of the screw outside of the bone?
That is covered.
What does the patient feel?
That is covered by the periosteum. Say that it does not. And when the pain goes away, there is no problem. It is just a prominence may be seen. That's all. If you see it very carefully, that's all. So that is to be kept for removal of the nail. And ultimately, actually, I have done number of them. So only very few people they come for the removal. That is the story.
Okay. There is a guy which is very famous in the shoulder world in United States, which is called Carl Bazamania. Carl Bazamania, very famous. And he developed an intramedullary nail of the clavicle entering from lateral to medial and not medial to lateral. Do you have any experience coming from lateral to medial, sir? This is a good question, sir.
Yes, that I have also done it 1 or 2 times, but it is a very difficult option. It's because actually there is a junction of the flat bone and the cylindrical bone. To make a window at the flat bone and cylindrical bone from the back, that is, there are muscles are there. So it is a surface marking and the dissection. You can do that. You can do that. But the dissection required is a very long to introduce the nail, one. And second thing, to find the canal. And here in the medial entry point, it is we are going through the soft bone. And therefore it is possible. And what they do, they don't do it by closed method. They do it by open method. And then retrogradely, they create a window there and then they pass it.
So just to check if I understood, to pass this message to the youngest, and then I would like to listen Dr. Guido, sir. What you mean is that on the proximal part, on the medial side, the clavicle is cylindrical, and on the lateral side is flat. And this is because, and this makes entering from the medial part, which is cylindrical, makes things easier. Am I right?
Yes, sir.
Okay, lovely. And you see, sir, I am very scared about damaging the subclavian artery, and before the patient having a heart attack of hypovolemical shock, me having a heart attack intraoperatively, you know, because jokes apart, it's a problem. I would say it would be catastrophic to damage, seriously speaking, the subclavian artery. How to be sure that you will not touch the subclavian artery, sir? This is a very practical.
Very good question, Sergio. Very good question. But
sure.
If you find the anatomical point of view, the neurovascular bundle is on the medial side, medial 1/3, not in the exactly in the middle third. It is medial 1/3, one.
Sure.
And then you will find that if you are not able, we are not hammering the nail because we are reaming it. So we have to ensure that you are exactly into the medullary canal. You are not out of the medullary canal. Therefore,
sure.
By C-arm, after giving a incision and then putting the this hole, we have to just move it, whether it is you are inside or not. So, and by pushing, by reaming also, you are not perforating the clavicle. Therefore, it will go through the canal only.
Sure, and sir, and it's important to the juniors to understand, always hand reaming, not drilling, always hand reaming.
Hand reaming. And then what we have to, then we have to pass the 0.5 mm less diameter nail so that it will go smoothly up to the fracture side. Struggle comes when you do a reduction and then negotiation into the distal fragment. So when this part is over, we have already crossed the neurovascular
fracture. Oh, yes. And then you are in a safe scenario.
Yes.
Because the nail is in the distal part of the clavicle. Now I understand. Okay, Dr. Guido, once again, because you are an AO faculty, before your statements, doing a mini open in this technique to achieve reduction, it's part of the game. It's not a sin. Do you agree with that? This is an important question to me, Guido.
Completely agree with Robinson. If you take care about the soft tissues, no problem. Doctor, not only incredible cases, really, congratulations. But I would like to know, how do you decided to fix a clavicle fracture with your enter point in the lateral point or medial point? How do you say? You say that usually you start with the medial point, but when you decided to use the lateral point?
No,
lateral entrance.
Actually, lateral point.
Yeah, exactly.
The lateral point is at the junction between the flat bone and cylindrical bone. That is there. But majority, they do it by retrograde method, and then they push the nail and it comes out of the clavicle. And that route they use it mostly, where it comes, because it's a curved bone. And therefore, I don't like that method of using from the lateral side. I use from the medial side. And also, there is one advantage. That nail is mostly elastic. Even if you use a steel also 2.5 mm, it will bend. So it takes the shape of the clavicle. And therefore, I don't prefer from the lateral. It is always from the medial side.
Always from the medial. And Dr. Gadegone, do you think that we can do that with ordinary key wires or not?
Key wires, I don't like it because they are stiff. They are sharp also, and does not give a proper, actually, it should be a malleable. You
mean elastic? You mean elastic?
Yes. Because these Kirshner wires are stiff. You can use L wires, elastic wire, nothing, no problem.
And what do you think? I am just thinking now about using the the Titanic elastic nails. Any clues on that, sir?
Titanic nails are very good because they are very easy to pass also, but there is a problem of migration because you don't have a support on medial and lateral side.
I know.
Yes,
I
and that is
understand
the problem because it gives a equally good result. Actually, reported literature is also a 95 to 100% union. There is no problem, but the medial migration, lateral migration is the problem. And suppose before union, if there is a, because whatever it may be the method used in the nailing, there will be an about 4 to 6 mm shortening of the humerus occurs, this clavicle occurs in a comminuted bone, not in a transverse. So what will happen? The length today appears to be very good, but after a sinking of the fracture, there will be a protrusion. So therefore, the migration of the and protrusion of the this elastic nail is a very common phenomenon.
Okay, and on the humerus, sir, see, you are not touching the rotator cuff, and I love it as a shoulder and elbow surgeon, but you were using the rush nails. Is this the rush nails?
Yes, yes, they are rush nail.
Okay, so I have seen some guys in the south of Brazil doing a similar technique on the humerus with key wires because of affordability, because of the economical system. Do you think that on the humerus it could be done with key wires?
No, I don't think it is, because again the K wires are very stiff. We need to have a elastic. And why I use a rush nail, it is because their hood at the tip that fits onto the metaphysis of the humerus. And in case if you want to remove it, you can just go and see the things so that the removal it becomes very easy. And there is a hook that fits into the metaphysis. So it prevents rotational movement also. Suppose a cylindrical thing, elastic nails or K wires, they don't have a head, and therefore it is possible that the humerus will rotate around that. So I purposely use the rush nail so that it hooks, that hook is sitting on the metaphysis.
Yes, just for people to understand, I am not exactly old. I'm 45, but when I was in my residency, people were using, I don't know if Dr. Robinson has something to say about the ender nails. I guess that Dr. Robinson remembered, they have what Dr. Wasudeo is mentioning, they have an eyelet in which you can put a hook and take them out. Yeah, the problem, Dr. Wasudeo, is that the ender nails, they are gone in Brazil, I'm quite sure. The rush nails, I'm quite sure that they disappeared from the market in Brazil in a way that reproducing your technique would be to start not feasible here because we don't have these implants. Just as a curiosity, Dr. Robinson, which is a fantastic trauma surgeon, have you used the ender nails, Robinho, or the rush nails, and they use it to work? Any clues about that?
Sergio, yes, I have used elastic nails for the femur, for trochanteric fractures, for diaphyseal humeral fractures. I had some problems of migration, but almost 100% of healing. It's fantastic. No, I have experience when doing that in the past. And I have used the rush nails for diaphyseal forearm fractures. No, I have some experience because in the past I did it. It works very well. It works.
Yeah.
If you respect the biology and soft tissues surrounding the fracture site, it works very well. No?
Yeah. You know, I've been following the Indian trauma market or the Indian trauma scenario for so many years. Dr. Wasudeo knows that. And intramedullary nailing all around the humeral body is the human bones is very common in India, much more than in Brazil. So we learn a lot with you, sir. But you see, minimally, Dr. Robinson, he knows that so much minimally invasive technique is the way in long bones. I mean, the philosophy, the meeple philosophy. It doesn't matter if with bridge plates or with intramedullary devices. And this is what you are doing now. So it makes a lot of sense in this way. And I think that it's very interesting to see, I would say, so affordable devices for us to do that. I have another question, sir, as a shoulder and elbow surgeon, which is sometimes I saw that you enter on the humerus from distal to proximal. This is what it's known in the literature as the Eiffel Tower technique, because it reminds us of the Eiffel Tower in France. If you do that, you have to come with one nail from the medial side and one from the lateral side. Once you do that, how do you manage the ulnar nerve? Do you do a small incision to see the ulnar nerve? This is a very practical issue, Dr. Gadegone.
Unless, Sergio, sir, it's very good question. We have to just see the ulnar nerve. It's not a blind technique. You give a small incision, ulnar nerve is posteriorly placed, so the nail entry of the medial side is anterior, whereas on the lateral side it is on the mostly posterior.
Okay, but you mean it's far away from the nerve, it's a little bit proximal and anterior to the medial epicondyle.
Yeah, exactly. You just cannot pass through that, otherwise it will probably damage the ulnar nerve.
Sure. This is very important.
Unless you just open it, small incision, see the location of the ulnar nerve. And you not dissect it, but we have to see the location, because you know,
sir, I teach our residents that we do a small incision, just as I say, just to see that you are not seeing the nerve, just to see that you are not seeing. So I learned it in United States, a very important phrase: when you know where the nerve is, you know where the nerve is not. I'm going to say it again. When you know where the nerve is, you know where the nerve is not. So it may sound obvious, but it's quite, I would say, it's not redundant. It's quite important. So, but see, it's a beautiful technique. There's a message to the juniors that we cannot do this with key wires, but with elastic nails. And I don't know if Dr. Guido has any questions to Dr. Wasudeo about that before we start seeing Dr. Robinson's lecture on the clamshell technique, in which Dr. Hélio will do a lot of help in understanding, in making us understanding the technique. Guido, any final issues on Dr.
No, it's okay. I just only say bye because I need to go to other course.
Yeah.
Sorry, but in 7 minutes start the other course. So
okay.
They are waiting for me. So sorry very much. It was wonderful.
It was a pleasure to have you here, and we continue here now.
My pleasure, really. My pleasure.
Okay. Thanks a
lot.
lot.
Thank you.
Okay.
No, thank you.
So lovely. So before we start, but see, sir, it's a beautiful technique, and I'm really thinking about moving to intramedullary, I would say, fixation of clavicle, because it makes a lot of sense in my mind, and we would, I would say, avoid a lot of soft tissue damage that we do, or that we tend to do once we do plating of the clavicle. Having said that, before we start with the clamshell technique, to which I'm very curious about, just to know, Hélio, any questions to Dr. Wasudeo, or we can move straight to the clamshell, in which you will help a lot, but which is from Dr. Robinson, or any questions to Dr.
Sergio, I want to add one thing. This is a retrograde insertion by this Eiffel Tower technique. It's not that simple, as I will show. It's because when you pass a nail from medial or lateral, there is if you don't mold it properly, there is a translation of the fracture fragment. And once translation occurs, it is very difficult to reduce it because it has gone already upside. So we have to find out the translation. It is like a very tricky thing. So both the nails
I know.
in a reduced position, and then you can execute. Such is not the problem with the antegrade, because antegrade nail they fan out here and there with the reduction. So therefore, I tell you to start with one must start with antegrade. After becoming a more and more versed with the reduction technique, he should go for the retrograde.
Yes. There is a message for the audience, for the juniors, which is, if you have to start Dr. Wasudeo's technique, you should start up to down and never down to up, because it's more difficult. And you know, sir, on your technique, I would say quite scared of doing a lot of maneuvers to achieve reduction. And in that sense, I would say not intentionally damaging the radial nerves. So this is something for us to think about too, sir. Yeah, before you speak, sir, and then you say this, and Dr. Robinson will move to the clamshell. I would think, sir, that when doing the antegrade nailing, someone would have to be doing traction all of the time, not only to achieve alignment, but to protect the radial nerve. Do you agree with me, sir?
Yeah, I agree with you, but humerus reduction is not a very problem. First, you pass because the medullary cavity, if it is 8 mm, so you are passing only 2 to 3 mm rod. So it is go very easily. And at the fracture site, you would hold it by a surgeon, and somebody else is pushing the nail. That can be done and see under imaging. If you get a reduction and pass the nail, first if you pass a one nail, then rest of the nail
then
will...
the rest is easier, definitely. Yes, very nice. Sir Robinson, any final questions to Dr. Wasudeo before you start, or you can start now?
No, Sergio, congratulations, just congratulations. Very good techniques.
Okay, so now we will see Dr. Robinson's lecture on the clamshell. This is something new to me. I'm gonna pay a lot of attention to see if I can grasp some ideas to move to the humerus. Hopefully we have Dr. Hélio to comment, but you can start now.
Okay, can you see the presentation, Sergio?
Sure, you can.
Yes, okay. First, thank you once again for this opportunity. There is some noise in the background. Okay. This is just another way to correct post-traumatic deformities of the lower extremity, and I will present the clamshell technique. This is my disclosure. I have to present to you that I have a conflict of interest because I am consulting of some companies that develop nails, and I will present a nail technique to correct deformities of the lower extremity. But the goals of this presentation are to present the principles of the clamshell osteotomy to correct post-traumatic deformities of the lower extremity, to present some rationale in terms of indications and contraindications of this technique, to present the step-by-step of this surgical procedure, and to present some tips and tricks to avoid complications and optimize outcomes. So when dealing with post-traumatic deformities of the lower extremity, we have several possibilities in our therapeutic arsenal, including the circular frames, the more fancy hexapod frames, Taylor hexapod, several possibilities. But even for developed countries, cost effectiveness matter, no? And it's important for us as orthopedic surgeons to have several possibilities when dealing with this kind of problem to solve this problem. And I will show you some possibilities to solve this kind of problem when treating complex deformities. This is a very, very interesting technique published several years ago by Bruce Sanderson from the United States of America. And this is a mathematically directed single cut osteotomy, an oblique osteotomy to correct a multiplanar deformity of the tibia. This is a very, very interesting technique, very clever, but when doing this technique, you must be 100% precise. You must address 100% of your talent to address and to correct the deformity using this technique. It works very well, but you must be precise. This is another paper using this technique published by Professor Roy Sanders in 1995, and he did this procedure, and you can see here the correction, very elegant correction of the deformity, and it works very well for lower extremity deformities. Coming from the more modern techniques, this is a paper that was published 4 years ago when the authors performed a computer-assisted oblique single-cut rotation osteotomy to correct a post-traumatic deformity of the tibia. And you can see here a very, very elegant technique when the authors performed the correction at the computer before to increase the safety of the procedure. And after that, they were more confident to correct the deformity and to fix using a long plate and some leg screws. And you can see here the correction of the deformity, some degree of shortening, of course, but the correction was very, very successful. We have the possibility to correct deformities of the lower extremity using nails. Here you can see a very, very elegant technique using an intermedullary saw to perform some transverse cuts around the whole femur to correct an angular deformity, as you can see here in this paper from Clifford from the United States, published by Clifford Jones. And you can see it seems like the soft field for pediatric femur deformities that was published several years ago. And this is a very elegant technique. But if you have an obliterated canal, it's impossible to do this technique. And if you have to perform several cuts, you have several places for healing. And this is another issue when doing this technique, but it works very well. I don't use the clamshell technique for every single case. I just have one more possibility to treat my patients with a malunion using the clamshell, but I don't use this technique in all cases, of course. This is a patient, a male patient, 61 years old, who suffered a car accident 25 years ago, and he presented this diaphyseal malunion and knee disarticulation. This patient was not able to adapt a prosthesis, a below-knee prosthesis, because he presented an anterior pain in the anterior surface of the thigh. And this patient was not able to adapt a prosthesis. And unfortunately, this patient fell down and presented these both fractures, one subtrochanteric fracture and one distal femur fracture distal to the malunion site. And now you have a major problem here, because we have a malunited femur, and we have a subtroch fracture, and we have a distal femur fracture in a very poor bone quality, as you can see here. So we have the possibility to do an amputation more proximal. We have the possibility to treat just the fractures and leave the malunited bone, or we have the possibility to try to solve the whole problem with a single procedure. And that is our preoperative planning. We tried to do a single cut osteotomy, a transverse osteotomy, and just perform a translation, an anterior translation of the distal femur. And here you can see the preoperative planning. the reduction of the subtrochanteric fracture was happened because I was not able to do it closely. And I put a small plate, just a reduction plate to maintain the reduction. And after that, I placed a nail, a long nail, and a long plate in the lateral surface of the femur to close the box and perform a more balanced fixation to achieve a more stable construct. And this is the patient 1 year after the procedure with the malunited side corrected and the fractures healed, and the patient was able to ambulate with an adaptation of a prosthesis, a below knee prosthesis. So starting with the clamshell technique, this is a technique that was published in 2009 or 2010 by a group from the United States. They are fantastic. They developed a very, very clever technique, very smart technique. And the principle is creating a comminuted fracture at the malunion side and using the rod, the nail, as an anatomic template for deformity correction. So it seems a little bit aggressive because you perform a transverse osteotomy and another transverse osteotomy and a longitudinal osteotomy along with the malunited side. But when doing this technique, you preserve the soft tissue surrounding the osteotomy site, and you can have the benefit of reaming the medullary canal and having a bone graft inside the osteotomy site. And you use the nail as an anatomic template for deformity correction. This is the key principle of using the clamshell technique. And the best part of this technique, you don't need to be 100% precise, because when using this technique, you have the possibility of minor errors and you are going to achieve the same result. You just have to follow the principles and the step-by-step of the technique, and you are going to the success. And this is the paper published in 2009 by George Russell, Matt Graves, incredible guys from the United States. And they reported a case series of 10 patients, 6 femur and 4 tibia. Actually, this technique is better for the femur because in the thigh, we have a greater soft tissue envelope. When dealing with tibial malunions, we have to take care about bony protuberances after the deformity correction, because this is a part of problem that can the patient can develop a soft tissue suffering and skin necrosis and bone exposure if you don't care about the soft tissues when using the clamshell technique in the tibia. And the authors reported 100% of osteotomy healing following these principles. So potential advantages of the clamshell technique are the preservation of soft tissues, reaming the medullary canal. This is the biological input, intermedullary nail as an anatomical template, and biomechanical issues of the intermedullary nail, the biomechanical advantages of the intermedullary nail. This is benefits of using this technique. Indications. The classic indication is the diaphyseal malunion of the lower extremity, when you don't, especially when you don't need an expressive lengthening of the limb. But currently, we use the clamshell technique for metaphyseal deformities as well. And we are expanding our indications and amplifying our indications for acute fractures in the malunion setting, and also for some rigid non-union in a deformity setting. Contraindications, osteomyelitis, poor soft tissues conditions surrounding the malunited segment, arthritis of the adjacent joints, because sometimes the nail can preclude a prosthesis placement unless you remove the nail after the healing of the osteotomy. And if you need lengthening of the femur greater than 5 centimeters of the tibia, greater than 3 centimeters, this is a relative contraindication for the clamshell technique. So this is an illustration of the paper of George Russell, illustrating the clamshell technique in the femur, subvastus lateral approach. It's important to do. It's very, very important to not use Homer retractors, because if you use Homer retractors when doing this technique, you can detach the soft tissue surrounding the osteotomy, and you can have problems of healing. The authors recommend, firstly, to apply 2 K wires 1 centimeter above and 1 centimeter below the deformity site, and after that, perform bicortical drilling using a 4.5 millimeters drill bit, like you can see here. This is the first step of the procedure. Preserve the soft tissues, and after that, you are going to perform an osteotomy only on the lateral surface of the femur. Please do not go through the medial side, because if you go through the medial side at this part, you can have an iatrogenic fracture of the whole femur. And this is a catastrophic complication if you don't follow this step adequately. After that, you are going to perform with a bone saw 2 transverse osteotomies at the site where you applied your Kirchner wire, like you can see here. And after that, you are going to perform an indirect osteotomy of the opposite side of the longitudinal cortex, the medial cortex of the femur. This is an indirect osteotomy using a chisel or using a spreader, a bone spreader. And another important part of this technique is do not rim the osteotomy side, because if you rim the osteotomy side, you can rotate your fragments around the osteotomy, and you can have a detachment of the soft tissues. When using this technique in the tibia, the steps are the same, but you have to use a 3.5 or a 3.2 drill bit, and the osteotomy, the direction of the osteotomy is different. The direction of the osteotomy is parallel to the anteromedial surface of the tibia, like you can see here in this illustration, because you must have a bicortical osteotomy. If you don't do it parallel to the anteromedial surface, you can have a unicortical osteotomy, and when you place your nail, the nail can be out of the medullary canal, and you can have a bony protuberancy and soft tissues problem, or the fragment can displace and you miss bone contact. So this is a case that is part of our series that we are about to publish in JBJS. Maybe in the next week, it will be published in JBJS, and I would like to show you the steps of this procedure. This is a patient, 22-years old, with a history of open fracture of the tibia 7 years ago. He was treated in another hospital with debridement and casting, and after that, he developed a diaphyseal malunion, shortening of 3.5 centimeters, claudication, and currently he was presenting knee pain and ankle pain. So this is the x-ray of the patient, and you can see here a varus malunion and some degree of shortening. And here you can see the clinical examination of the patient and the patient walking. You can see here the claudication, the varus thrust, and very, very poor quality of function. So this is the incision. The patient is placed in supine, and the incision is in the anterolateral surface of the tibia. This you can see here. For the tibia, of course, we need to start with the osteotomy of the fibula to allow for correction of the tibia. At this part, we can apply a humeral retractor because this is no problem, but we don't use humeral retractors in the tibia and in the femur. In the femur. This is the osteotomy of the fibula. And we complete the osteotomy using a chisel. And this is the x-ray. After that, we apply 2 K-wires above and below the malunited segment of the bone, like you can see here. We apply some solution to prevent overheating. And after we use 3.5 millimeters drill bit to perform the bicortical drilling, like you can see here. After that, we perform only the osteotomy of the lateral side of the tibia, and we don't violate the medial part of the tibia to prevent an iatrogenic fracture of the whole bone. Here, we perform with using a bone saw 2 transverse osteotomies at the malunion site at the level of the K-wire, proximally and distally. Okay, and then we use a bone spreader to perform the osteotomy of the opposite side, like you can see here. Using this technique, we don't violate the opposite cortex of the tibia. And after that, we use a reamer to ream the medullary canal, and we don't ream the segment of the osteotomy to prevent rotation of the fragments. Like you can see here, we did a semi-extension nailing in parapatellar approach, and we push the reamer crossing the osteotomy site, like you can see here. And this is the correction of deformity. And after correction, you have to palpate the osteotomy site to see if there is a bony protuberance. If there is a bone protuberance, we have to remove the bone protuberance to prevent some soft tissue suffering and skin necrosis. And this is before and after the correction. And this is the patient with 1 year follow-up with so much better function, even preventing some degree of shortening. But he is very, very satisfied with the result of the treatment. So this is another case. This is a patient, 48 years old, with 2 previous tibial fractures and tibial malunion shortening. You can see the overslope of the knee, and this patient presented pain in the anterior surface of the tibia, and you can see here a stress fracture because of the deformity. We did a preoperative planning, calculating the cora, but we did a transverse osteotomy just below the cora to address to perform the osteotomy at the level of the fracture, of the stress fracture, to have just one side for healing and not 2 sides for healing in the distal part of the tibia. Preoperative planning, The clamshell osteotomy, we did it medially because we had to remove the plate, to take out the plate medial, and we did the transverse osteotomy of the tibia medially. In this case, here you can see the clamshell technique and a suprapatellar nailing, correction of the deformity. And here you can see the patient 3 weeks after the procedure with equalization of the limbs. 5 months later, before and after the correction of the deformity, X-rays 7 months after, and the patient 11 months after the surgical procedure with a very reasonable result when the patient is walking. This is a paper that we have published 3 years ago in the Journal of Orthopedic Trauma, amplifying the horizons of the clamshell technique. This is a multicentric study in combination with Colombia and some colleagues from Brazil and some colleagues from the Hospital for Special Surgery in the United States, where we amplified the indications of the clamshell technique for acute fractures in the malunion setting. And this is a case of Professor Dean Lorish from the Hospital for Special Surgery. This is a malunited diaphyseal fracture, and this patient presented an acute subtrunk fracture, and Dean performed the clamshell osteotomy to solve both problems at the same time, the malunited segment and the acute fracture. And this is the result. And you can see here a very elegant technique with overlapping the nail inside the prosthesis to prevent some fractures in the stress area of both implants. So this is another amplification of the indication of the clamshell, that we are performing a case series using this technique, including for rigid non-unions. This is a case of a 21-year-old male patient with a recalcitrant non-union of the distal tibia. He had 8 surgeries to solve this problem. No healing, no signs of infection. You can see here 2 short plates. And this patient, we decided to correct the axis of the tibia and use a clamshell technique, taking out these plates to address correction of the axis, stability, increase stability, bone graft of the healing, and to perform 2 osteotomies, transverse osteotomies, and therefore we are going to have a vascular shock surrounding the non-union to increase the rates of healing of this patient. And that is what we did here. You can see the osteotomy of clamshell. You have used 2 polar screws to increase the stability of the fixation. And we have here the healing of the osteotomy and healing of the clamshell technique with some migration of the distal screw, some breakage of the last screw, but the patient is doing very well, like you can see here, with the correction of the deformity and returning to the previous activities. And this is my last case, another indication for the clamshell technique that is complex deformities in patients with diseases of the bone metabolism. And this is a patient, a female patient, 37 years old. She had several surgeries in the lower extremities. She has a hypophosphatemic rickets, and she presented several stress fractures due to the deformities and pain in both femurs. After a heavy discussion with this patient, with her family, after a long wait, and discussing the possibilities of treatment for this patient, including do nothing, we have decided to do a correction of this deformity. It's a challenging case because it's a multiplanar and rotational deformity, but I have decided to do a clamshell osteotomy first in the left femur and to see the result. And after that, if we get success, we would do at the same in the opposite side. And this is the patient. The intraoperative imaging, you can see here a stress fracture and a non-union actually. The clamshell osteotomy, polar screw to help the reduction. Of course, this patient presents a varus in the neck, but it's impossible to address this deformity at this time. And we did the correction of the deformity, like you can see here, using the clamshell technique, a retrograde nail with a spiral blade, and you can see the correction of the deformity. After a couple of months, the patient asked me, "Doctor, please do the same in the opposite side, because I am satisfied. I did not have any neurovascular palsy or injury. I am satisfied with the result, and I am satisfied with, including with the static aspect of my leg." It's important to emphasize that this patient presents the same deformities of the tibia, and she is asking me to do the same in tibia, but I am thinking about that first. So this is the osteotomy of clamshell and the opposite side with a more severe deformity. You can see here the rimming of the medullary canal and the same technique here. And this is the result of the correction of the deformity. And this is a couple of months later. Just here, you can see that the left side is healed and the right side is coming to the heel. It's not completely here yet. And this is the patient walking before the treatment. And this is the patient walking now. This was last week. You can see a very reasonable walking. And she is free of pain. And I'd like to share with you this experience when using the clamshell technique, including for severe deformities in bone diseases and in diseases of the bone metabolism. As take-home messages, I'd like to tell you that the clamshell osteotomy is an extremely helpful technique for the physical malunions of the lower extremity, because this technique preserves soft tissue surrounding the osteotomy size, and this is a key principle for getting success. And it's important, another step, to close the fascia before rimming to prevent, to avoid that the bone marrow can go out of the medullary canal. It's important to close the fascia before rimming. This is an important tip when dealing with this kind of problem. So that's it. Thank you very much for your attention. I am open for questions.
Well, let me tell you this. First of all, my dear friends, I am absolutely honored to have all of such lectures here, because you see, what a beautiful lecture, my good friend, from the bottom of my heart, beautiful cases, difficult cases. And it proves that we are really talking about unconventional scenarios. And so we selected very nicely all of the panelists. It makes me very happy. Beautiful, beautiful, difficult. I have never seen that before, but I understood it. And I would really like to listen, Dr. Wasudeo, especially Dr. Hélio. But before that, Dr. Robinson, let me ask you two questions. You create a segmental, in the end of the story, you create a segmental fracture, which lead you to two osteotomies, meaning two possible focus of non-union post-operatively, in spite of the beauty of the technical points. Have you ever had any non-unions on one of the sites? I hope not, but if you had, how to manage this difficult? It's already difficult. All of the cases, they are difficult, but have you ever had a non-union? If yes, how to manage that? This is a good question.
Yes, very good question, Sergio. Actually, this is not a segmental fracture that we create, because we create two longitudinal osteotomies as well. And it works as a comminuted fractures, comminuted fracture with a low strength, strength. And we have the input of their biological reaming, and you have the combination of mechanical advantages of the nail. Sure. And the incidence of non-union when dealing with when using this technique is very extremely low. Okay. Zero in the case series of the George Russell. In our case series, I had just a single case. I have maybe 15 cases of clamshell osteotomy, and I had one case of non-union that I used the clamshell technique using a plate, not using a nail, because this patient presented a knee arthrodesis, precluding the possibility of using a nail. I had to use a plate, and I lost the possibility, the advantage of the mechanical advantage of the nail. So, but if you have, it's possible, of course, but I think it's more easy to have a non-union if you length and if you don't have a bone contact, and using because it's possible to use the clamshell technique believing that you are going to have the periosteum preservation and try to have some degree of lengthening, but you lost bone contact and you increase your possibility to have a non-union. Okay. So,
my last question before I listen to all of the panelists, especially Dr. Hélio. Do you think, I am learning a lot here. Do you think that we can do some lengthening? I'm sorry you mentioned that, but some lengthening in this technique without increasing too much the chances of a non-union?
Yes, it's possible. It's possible. If you believe that you can have a preservation of the soft tissues envelope and some degree of preservation of the periosteum of the opposite side of the osteotomy, it's possible. I don't have any single case that I did this technique. I am a little bit afraid. I like to have some degree of bone contact, but I have seen one case presented by a colleague from the United States where he addressed a malunited, terrible case using this technique and even using the lengthening of around 1 centimeter, and the osteotomy healed. It's possible, but if I need lengthening, I usually don't use the clamshell technique, or I use the clamshell technique, and after healing, I can use, I can perform an osteotomy and use an external fixation over the nailing to correct the limb discrepancy. Okay?
Okay. Very difficult scenarios. Dr. Wasudeo, and Deck, I'm very anxious for Dr. Hélio's comments, but Dr. Wasudeo, your comments first. Beautiful cases, Dr. Gadegone.
Robinson, excellent presentation, excellent cases, and I am mesmerized. Actually, I have not seen before. I have just
Professor.
Techniques, but there is one or two questions. When you do an osteotomy, longitudinal as well as a transverse, there is a lot of bleeding. How you handle one question, and second question, even after a fascia stitching also, there is a lot of blood will be there, will be seepage, because it's all raw bone. So how you manage these two conditions? Because you don't keep a drain, I suppose. You only do an osteotomy and close the fascia. No drain is required in this in Europe because you have not shown the cases like this. So how do you manage this? Because compartmental syndrome may be the possibility.
Okay, good question. Very good question.
Very good questions. The first one, I usually, it's completely true. I agree with you that we are going to perform a comminuted fracture, and there is an important bleeding. There is a source of bleeding, and we use the tranexamic acid. Is it the transamine?
Yeah.
No? Before
In
acid, tranexamic acid.
Yes, just
Yes.
for people to understand,
Yeah.
the name of the product is transamine. It's the
Transamine.
tranexamic acid. It's
Acid.
very interesting,
Yes.
but you go on.
Yeah, I used that before the surgery. It make a little bit sense because the replacement surgeons, they use it very
Yes, all of the time.
very all the time, and I use it for correction of fractures in the lower extremity, and it works for me. So it's an important source of bleeding, but it's not in at least in our case series. It was not a huge problem, or we don't need so much transfusions. It's not a major problem in our clinical practice. And regarding the possibility of compartment syndrome, because we closed the fascia before reaming, it's a reality. So to control the possibility, we try to do as much as possible an atraumatic osteotomy, and to ream, to excessive over reaming, to avoid excessive overheating, and but actually this is a possibility, and we have to be careful about that in the post-operative period, and we have to take care about the possibility of compartment syndrome. This is the reality. But in our series, we didn't have any compartment syndrome.
Robinson, just a second, sir. Robinson, considering this brilliant point pointed by Dr. Gadegone, wouldn't you think that putting for 24 hours a drain would be reasonable?
Yeah, it's a possibility. It's a possibility, but Sergio, in my practice, it's a possibility, but I just use drain in one possibility in my when I use huge approaches like the modified Jude approach for the scapula. Because I am a little bit afraid of infection. Yes, I don't like. This is a personal point of view, just a personal point of view. But it's a very reasonable thought that using a drain, you can prevent some bleeding inside, and of course diminish the possibility of a compartment syndrome. This is a possibility, but personally, I don't like that. No.
Another question, Robinson, because after malunion, you are straightening the limb. So there will be a disproportionate length of the muscles, soft tissues, as well as the bone. I suppose if you say there are adductor contracture, say add adduction deformity, you have abducted it nicely. But what about that disproportionate stretching of that particular muscles and tissues? Is there any problem of cause or worry in future? Because suppose if there is a quadriceps, take example, so probably you may have some problems in knee bending, or in hamstring there is a problem of extension. So do you find such a scenario in your practice?
No. It's a concern. I completely agree that when using every technique for lengthening or for correction of post-traumatic deformities, this is a possibility. But the clamshell technique, usually we can When we correct the deformity, we can gain around 1-2 centimeters in average. And this is not enough to cause some nerve palsy or some muscles excessive traction, and that can cause a post-operative problem. It's a major problem, in my opinion, in the tibia than in the femur, because we have a greater envelope of soft tissues. I didn't have any problem regarding this situation, even in the femur or in the tibia. But this is part of the problem. We have to keep this possibility in our minds. And but I didn't have this problem. At least yet, I didn't have it. But I was extremely careful, especially in this last patient. Because the deformity was important. And then maybe we gained around 3 centimeters using the clamshell. So we have to be careful about that. But we didn't have problems.
Yeah, I just want to make a statement, very interesting statement, and then I would really like to listen to Dr. Hélio. I don't want to change the subjects, but just for the audience to understand, as we have to think about the principles. When you do a reverse arthroplasty, this is my universe, for a typical case, a massive rotator cuff tear, with anterior-superior scape of the humeral head, we always do some lengthening of the arm. So we have two phenomena, a lot of pain in the deltoid, Dr. Robinson, because we tension the deltoid. This is the same thing you were mentioning. When you tension the muscle, you have a lot of liberation of lactic acid, and it pains a lot. And I've never had any neuropraxis of the hand with a reverse arthroplasty, but it's described in the literature up to 2%. So the idea is the same. When you do some lengthening of the limb, you may have all of these problems. But you see, hopefully you didn't have it, but definitely it's a concern. Dr. Wasudeo was absolutely sure in his, not in his fears, but in his, I would say, expectations of, I would say, problems of or complications in this sense. But now I am very interested on everything that Dr. Hélio has to say, because it's a pleasure to me and an honor to have a reconstructive and Ilizarov surgeon to make some counterpoints on this technique. Dr. Hélio, the microphone is yours.
Oh, okay. I'll start with the possible nerve palsy. My experience is that in post-traumatic deformities, you don't have to worry a lot about nerve palsy, because the original member length, the nerves, they don't suffer the shortening that the bone suffers. So I wouldn't care about nerve palsy in acute deformity correction in post-traumatic fracture, in post-traumatic deformities. But on congenital deformities, the nerve palsy is a risk. When you have like the last case, Hobson showed, I would be worried about nerve palsy lengthening the femur or even the tibia. In the external fixator, you have the possibility to control the rhythm of lengthening. So if I have to correct a deformity in a congenital patient, I would, at least in my experience, I would prefer the external fixator. Now, about the clamshell, I think, as Robson said, is an elegant alternative to the external fixator, but I think it's not as biological as a correction with an external fixator, a circular or an hexapod fixator, because of the soft tissue lesions. When you do the osteotomy in an external fixator, you usually do it by percutaneous access. The classic osteotomy, Ilizarov osteotomy, you preserve the periosteum, and the more common nowadays, at least in Unifasp, in the Federal University of São Paulo, we use jiggly saw. So it's a small incision, and usually we don't care much about blood loss and soft tissue lesions. I think that another risk in clamshell osteotomies is the risk of implant failure and implant infection. In the correction with external fixators, you don't have to worry much about implant failure. You can have a more stable fixation or a more elastic fixation by the choice of the surgeon. And in the nailing, you have to believe in your intermedullary nail. You have to be sure to have a secure fixation. I believe that the future is internal implants, but I believe in the telescopic nails. I think the future in deformity correction is an acute deformity correction with a lengthening with telescopic nail. I have no experience with clamshell osteotomy. I have at least a small experience with acute correction and nailing, or external fixation associated with nailing, and the nail usually makes us worry about infection. To treat a post fixation infection with the nail is harder than just correcting the deformity. I think the risks of infection in nailing are more worrying than just the correction of the deformity. That's why I tend to use more external fixator. I would like to hear Robson's opinions about what I just said, but
this is very important, because actually we are dealing with a problem, and for this problem we have several possibilities, several solutions. This is important to not use only a unique technique to correct all problems. You have to have several possibilities. You can use a single cut oblique, you can use an external fixator, and you are going to customize your treatment according to the patient's necessities, to the patient's needs. So it's important. You have actually a chance of infection when using a nail, 2 to 3% of chance of infection when using a nail. It's important. It's not zero. You have the possibility of overcorrection, undercorrection. You have some drawbacks when using nails, but you have potential drawbacks when using external fixation as well. We have the psychological problem of a patient. We have the difficulty of daily activities, including take a shower. You have several problems of pin tract infection that in my cases, they occur in 100% of cases if you have a long-term use of the external fixator. So we have problems in all techniques, including clamshell, external fixator, plates, nails, casting, everything. So this is important to have several possibilities and customize the treatment according to the patient needs. No? This is my point of view.
No. And Robinson, and according to the doctor's experience too, we cannot forget that.
Yeah, you have, yes, this is true, of course. If you don't have experience using one technique, you can't use it. But
sure,
the best scenario is to have the skills to do all of them. No?
I agree with you. And I think that what you just said, the main indication is the patient's acceptance. The internal fixation, the internal implant is usually the patient have a better acceptance with the internal implant. But about the daily labors, I don't have that problem with my patients, at least my private practice patients, because when you have good physiotherapeutic when you have I'm sorry, I'm losing the words in English, but when you have good physiotherapy in the post-operative, the post-operative.
You mean when you have a rehabilitation background?
Yeah. When you have good rehabilitation in the post-operative, patients usually do all they can do. They go to the gym. They can take a shower. I don't see that as a problem in external fixation. But yeah, I agree with you about having the all kinds of techniques available to treat the patient. I believe it's a good alternative.
Lovely. Dr. Hélio, I will just ask you to adjust your camera because
sorry.
And now you're seeing a face. Yeah, lovely. So, but see, there's a message in this case, which is, as I learned it a lot of times, there are many ways to skin a cat. There are many ways to go to Rome, but the surgeon is the method. This is one thing. But one thing that I see, Dr. Robinson, just to mention, in our public hospital in which Dr. Hélio does the Ilizarov cases, is that when the patient comes, especially with an infection, with a chronic osteomyelitis on the tibia, he's so desperate, he's so bothered with the scenario that they accept the Ilizarov very well. I'm not changing the subject, but I'm just mentioning that when the patient comes with osteomyelitis in the femur, with a sinus and pus, this is a tragedy. Hopefully it doesn't happen too much. But the acceptance in, I would say in these cases, it's not exactly a problem, but we have problems all of the time with all of the techniques, as you mentioned. Another thing that I would like to ask you, do you think that, I know that it's very uncommon, but in a serious deformity in the humerus, we could do that in the humerus, Dr. Robinson?
Sergio, I don't think so. I don't have experience using this technique. I don't have that. We have the advantage, the mechanical advantage of a nail in the humerus, because but we, at least for not for the technique that Dr. Gadegone had presented, but when using interlocking nails in the humerus for shaft fractures, I don't see a very helpful this technique as a helpful technique. So and I am extremely afraid about the radial nerve when correcting this deformity and doing an osteotomy surrounding the nerve. I don't think that the clamshell technique is a good alternative for the upper extremity,
I'm just thinking,
including the humerus.
I'm just thinking now, you know, I never thought about it. It's just an idea. It's just an idea, but it's a beautiful technique. And in the end, I like it when you mentioned that in spite of having, I would say, two transverse fractures in what would induce to two focus of possible non-union, you have a whole scenario of a big comminuted fracture, a lot of bleeding, which would make the possibility of non-union quite improbable. So that's a very interesting point. But I just see the idea that making when you can do a progressive lengthening of the limb, I would say with an external fixator, that would be a much more controlled environment than doing something, I would say, acutely, even because, as Dr. Gadegone mentioned, and I have this concept, acute lengthening of the muscles and of the nerves can be a problem. So this is something that we really should keep in mind. But you see, all of the techniques, they have advantages, disadvantages. So we really have to think about it. But see, it was a beautiful presentation, beautiful documentation.
Thank you, my friend.
Yes, I'm very happy.
Robinson, this
Professor.
is a technique, but there are two questions. Is there any increased angiogenesis and osteoinduction properties after doing so much community? Is there any study on this thing? That increased neovascularization.
Can you make the question again, Doctor? We didn't understand you, sir.
Yes. There are two possibilities here because there is no non-union scenario which I had described in all cases. Is there any possibility of a neoangiogenesis, one, and second, whatever these osteotomies, they produce a new environment and new osteoconduction and osteoinduction?
Yes, I think so, because you have, when you rim the canal, part of the bone graft is inside the environment of the osteotomy site, and we have cells that can deliver the properties for bone formation. I agree with that. And if you do an osteotomy in an intact bone, the first stage of the bone healing is increasing the angiogenesis around the osteotomy site. And I completely agree that this is a potential advantage of the technique.
Yes, but even just for the juniors to understand, Dr. Robinson, I guess I'm right in what I'm going to say. This neoangiogenesis would be possible because with the rimming of the intramedullary canal, you would release. Yes, both. Yes, both. You would spread a lot of mesenchymal cells and stem cells on the focus. So you see, the beauty of that is that in spite of being, I would say, a lot of times, I would say complications, chronic cases, sequelae, you are adding biology to the scenario, which means blood. So it's a possibility, you know, it's a possibility. Sure.
When you do an osteotomy, you are provoking vascular shock, and when you rim the canal, the first stage is an over vascularization of the periosteum. That there are some studies showing that when you rim the canal, you can cause some devascularization inside the medullary canal, but you increase the vascularization of the periosteum in the following weeks. And after that, we recover around 8 to 12 weeks, you recover the vascularization of the endosteum as well. So Dr. Gadegone is completely correct in his thought, because we increase the mechanical and we increase the biomechanical environment for osteotomy healing.
Okay, that's very nice. Well, you see, there are a lot of people that are asking Dr. Gadegone's email, but don't worry, we can share that with you after that. Don't worry, I can manage that with Dr. Neeraj Bijlani. And the thing is, well, I have a last question, which is, you said that you always were putting all of the small holes to make the osteotomy easier. Lovely, and I think that this is very important. This is very important to create, and I would say a bigger osteotomy than you want. What I want you to understand is that you mentioned it, that you do the clamshell, so you only open one of the corticals. If you open both of them, why would it be so bad? I didn't get this point.
No. The technique, we open both longitudinal. Both. We do firstly just the osteotomy in one cortex of the tibia, for example. We perform the 2 transverse osteotomies, because if we do the longitudinal osteotomy at the same time, we can create an iatrogenic fracture.
Now I understand.
Expanding the osteotomy, and we can create a whole problem. So we do just 1 longitudinal, 2 transverse, and we applied a bone spreader, and we perform an indirect osteotomy of the opposite side, because we did a pre-drilling. We did a pre-drilling. We perform, we did a pre-drilling in the opposite side.
In both sides. In both sides.
And we use a spreader, and we can apply and open the edge, and we perform an indirect osteotomy of the opposite side. And therefore, we preserve the soft tissues and the periosteum as much as possible. I
understand. So you see, in this sense, in spite of being the tibia, which is not, I would say, so well vascularized, especially in the middle and in the inferior part, in this sense, you agree that there is no need to put, I would say, cancellous graft from the iliac crest or things like that. It's not needed.
Definitely not. It's not necessary.
Okay, very nice. Well, you see, we are 3 hours now. I love these webinars because time passes and flies, and we can talk a lot. But see, Dr. Gadegone, do you want to say any final statements?
No, I only congratulate him, and it's a mesmerizing procedure. And next patient comes, I will try.
Fantastic.
Next, I will try.
Yes, I am really thinking about making another webinar about complex scenarios in the humerus. I already have the idea of inviting you both. Actually, on inviting even Dr. Hélio, because he has a beautiful case in which he used an Ilizarov in the humerus. So I am already organizing everything in my mind. But I'm very happy that we discussed different scenarios. And you see, I have a confession, which is very easy to me, is that I am a shoulder and elbow surgeon who does a lot of shoulder and elbow trauma. I work with orthopedic education, and I don't want to stop talking about the upper limb. But this is the first. I am celebrating, or I am achieving at least 1 year of webinars with OrthoTV. This is the number 8, and I am already thinking about the number 9 and number 10 and number 11, and always ideas in my mind. But after 1 year, as a coincidence, because the first was in June last year with OrthoTV and SHOULDERPLANET, this is the first time that I can achieve things that go beyond the upper limb. So I'm very happy because I learn a lot. And orthopedics, Dr. Robinson and Dr. Wasudeo and Dr. Hélio, orthopedics is orthopedics. It's not only the upper limb, which is my universe. So I'm very happy that we could achieve different scenarios, different things. And, this is the benefit for all of us. So I guess that we can finish as we are, I would say, 3 hours and more than 3 hours talking. It's a big honor to me to have you all here. I love to do documentation. I am paranoid and obsessive about documentation. So when I see another crazy guys like me, Dr. Wasudeo, Dr. Robinson, doing this crazy documentation, which is not easy to do. We know that it's painful. It's painful to keep all of, yeah, you know, I know that this is my life. I always say I have a very comprehensive wife who doesn't get angry with me when I am organizing my pictures and my videos on Saturday evening and on Sunday. I like to do that, but it's painful. So we know that, and I really appreciate to have such, I would say, good surgeons and presenters to help me in this endeavor. So Dr. Robinson, please, your final statements, and then Dr. Wasudeo and Dr. Hélio. I am already inviting the three of you to a next webinar in complex things around the humerus. We have the lectures, everything's gonna be very nice. But I would like to listen to you guys. Thank you again for your final statements to OrthoTV and to all of the audience, because without the audience, Dr. Robinson, this is useless. This is not for all the four of us. This is for the whole world to learn. And this is what makes me extremely happy. So having said that, your final words, and that on Dr. Wasudeo, and then my good friend who works with me in presence, Dr. Hélio. Dr. Robinson.
So, Sergio, thank you very much. I was fortunate to be here, and I learned a lot from all the panelists here. And I'd like to thank you and OrthoTV to make possible this room to have a more closed relationship with the Indian surgeons, because I know that they are very, very talented surgeons, and it's a gift for me to be here. And thank you very much for this great opportunity.
Definitely. You know, one of my missions, and this is a formal mission of OrthoTV, I can tell you for sure, is to make bridges. So we are, as Dr. Robinson has said, we are augmenting interaction. And, you know, and the thing is, we cannot grow only alone. We have to join forces to I would say, to grow together and to develop education, because this is what we like to do a lot. And this endeavor will continue. And again, without guys like you, all my efforts and all OrthoTV efforts would be zero, because we have the tools, but to make the interaction, but we need people and talented, and I would say, and talented people, and people especially who dedicate their precious time in which they could be with their families, but here 3 hours with us. And Dr. Wasudeo, I guess it's around 8:30 in the evening, sir, or something like that. Okay, we are bothering your dinner, and I am very, very, I would say, honored for that. But Dr. Gadegone, this is your first time in this webinars, not the last. I will not let you go, sir. Okay, you will keep with us with a lot of time. But your final words, sir, please.
So this is the first interaction, Sergio, because I have not personally met you, and you included me in this webinar, because I deliver so many webinars in India along with stalwarts. There is no problem. OrthoTV people, that Neeraj, Bijlani and Ashok, Shyam, their name will be written in the history of orthopedics, because there are so many things. They are dissipating the knowledge and spreading the knowledge is very important. They are educating the people and younger generation, and they will continue to do, and they are doing it regularly. Robinson, I have learned from you a very good technique, and probably it will be one of the best thing that value addition in my knowledge. Then Guido also has given a soft tissue problems. So it is not the domain of a plastic surgeon. Orthopedic surgeons also can do techniques, and there is no problem. There is nothing very complicated thing. Only we have to learn the anatomy, vascular and nerve supply. Hélio has commented on many aspects, and probably he will deliver next time. And Sergio, you are not a shoulder surgeon. You are an orthopedic surgeon first, and then you are a shoulder surgeon. So therefore, it is always better that you organize not the shoulder only, because it will be a monotonous thing. You should have a all skeleton from scalp to
sir.
toes.
You know,
involve the people, probably centralizing over the shoulder theme. So Robinson, I think he should organize in a such a way that everybody get interested. Otherwise, shoulder,
definitely,
only that capsule, shoulder, greater well, lesser tuberosity, and that labrum, and it is that things are becoming.
So, sir, I'm gonna say something. I am very transparent as usual. I was afraid. So this is a present to me. This is a gift to me before we listen to Dr. Hélio, because I was really afraid, and I was talking last year with Dr. Robinson, that I was afraid of losing my identity if I started talking about other things that not the upper limb. But now I am realizing that I can still do this without losing my identity. So we are amplifying not only the trauma, but with this event, I am starting to amplify SHOULDERPLANET to other parts of the human body. So that's a gift to me, and I wouldn't be able to do that without you. So Dr. Hélio, thanks a lot. I'm counting on you to the beautiful case that I know you have to show us in future. I hope in next future, in quite soon. But I really want to thank you, my good friend, and listen to your final statements. And then I'm going to do speak 1 minute, and then we will listen to Dr. Ashok Shyam. Dr. Hélio, please.
Yeah, I would like to congratulate the colleagues in all presentations, especially Robinson. Now I'm inspired to try some clamshells. I would like to thank Sergio. We're good friends, and I only have good things to talk about you, and I thank you for the opportunity, and that's all. Thank you.
Okay, lovely. So one thing that I really have to say before we listen to the end on Dr. Ashok Shyam is this. I thank all of the audience again. Without you, my good friends, I guess from many countries, this would be useless. And I really want to say thank you to OrthoTV, because Dr. Ashok Shyam, he is dedicating not one weekend, but all of the weekends to do all of these things. And but I'm very happy to say, and I'm very happy to announce that we are achieving a lot of good things with OrthoTV in South America. We started OrthoTV Iberoamerica, and a lot of societies, they are coming to join us. The Brazilian Society of Orthopedic Oncology has already made a formal partnership, and other groups have been asking me, and Dr. Daniel Moya, who helps us a lot too. So thanks to Dr. Daniel and Dr. Ashok. This is a lovely opportunity. I just have to say thank you. We will do a next one, I would say in less than 2 months. I just have to organize things. But thank you all, my friends, and we have to listen to Dr. Ashok before we finish this wonderful event.
Thank you, Dr. Sergio, and I'd like to thank all the faculty, Dr. Hélio, Dr. Robinson, Dr. Sergio, Dr. Wasudeo GADEGONE. Yes. So it was really an amazing experience to listen to all of you talk about such unusual solutions to such difficult problems. And this is what we need across the world. So this is like continents coming together and sharing their knowledge so that the patients from both the continents are getting help. So we recently did a kind of questionnaire survey about what is the impact of OrthoTV across, and the best opinion or the answer that we got is that this is helping us treat our patients better it is reducing complications in our patients, and it is helping us give a more optimal treatment for our patients. I think that is what the aim of all these webinars are, not individually, but collectively also. And that is the aim of all of us here, to help everybody who is watching this treat their patients better, reduce complications in them, and if there is an unusual situation, unusual fracture, how to deal with it, how to think, how the thought process goes across continent. How does the thought process go in Argentina? How does the thought process work in Brazil and in India? So this coming together of various thought processes is what we aim for, and I think we achieved it fantastically in this particular webinar. So thank you very much, all the faculty, and thanks very much, Dr. Sergio.
Lovely. Yes, I just want to make a final statement. You know that by mistake, by chance, last week there was a guy, Dr. Ashok from Bolivia, from the city of La Paz, and he wrote to me because he wanted to join OrthoTV, but then he made a confusion, and then he said OrthoPlanet, not OrthoTV and not SHOULDERPLANET, but OrthoPlanet. And I said, no, excuse me, it's OrthoTV and SHOULDERPLANET. But jokes apart, this webinar has made me understand that we are still keep OrthoTV, SHOULDERPLANET, but we are creating an OrthoPlanet. Yeah,
absolutely.
So this makes me very happy. And just for people to understand, this event is going to be on OrthoTV YouTube channel. As usual, in a few days, I'm going to put in my YouTube channel too. I'm very honored, my good friends, as I am used to say namaskar and namaste to everybody. Dr. Wasudeo, you are already invited to something which we will discuss soon. And this is for the benefit. And just my final statement, if Dr. Ashok wants to speak 1 second, just for people to understand, it makes me very happy. We are not only talking to Brazil, Argentina, and India, we are talking to many countries. And what I'm very happy to say, and I didn't mention that to Dr. Ashok, yes, is that many people have been writing to me, Dr. Ashok, from Africa, from the African continent. Many people from Kenya, from Tanzania, from Namibia. I never thought we would reach those people, but we are. So this is something that really, I would say, really makes me happy, because we are not in South America, we are not in the Asian continent, we are going to other parts, very distal parts, literally other continents in the planet. So more or less, this is OrthoPlanet.
No, we are reaching more than 75 countries across the world. So
okay.
That is the data we have.
Yeah. Okay. So that's it, folks. Thanks a lot. Thanks, everybody. We keep on talking, and it was a pleasure. See you soon. Thank you. Thank you, OrthoTV. Thank you. Bye-bye.
Thanks. Bye-bye. I'm stopping the streaming.